We're intended to hear anything that's being said. We're not hearing it. Oh, I see their mic is off. That's why.
How about now?
Hi.
Perfect.
Hi, Barb. Hi, Jean.
Hi.
We don't have a turn
Sorry,
on
we missed the tour.
volume on this thing.
It's
right
a
now.
great facility. It's amazing what they're doing.
Do
So
we know if we can amp up the volume on this?
So I mean, you may just be able, it's like my private computer, so it may just be on the card, you may just wanna just do the basic.
I think it's at the max here. It says it's at 100.
There's 0.
can you hear us okay? I'm
That-
sitting right next to it. Maybe somebody at the end of the table should talk.
Can you hear me okay?
Yeah, I can human microphone if we.
Yeah, I'll figure it out. So thank you all for coming to Connecticut Children's Fund, near and dear to my heart, but I hope, I would like to bring in a couple patients to meet you, but obviously. People will not allow me to have them on a YouTube platform, but this is where the work is done, right? This is where I live, and this is where everything we're doing is about these little humans you see, so. I hope it gives you a little bit of a sense and the opportunity for growth. The fetal care is something that I'm involved in, and many of those fetal care patients, certainly the ones that deliver here, our team is involved with those patients and will be involved with those patients. So every space that you just saw, there's a palliative care supplemental kits footprint that will continue to expand. So all of this work, all of the resources that we're asking for are going to benefit all the things you just saw and all the opportunities that it brings. So overwhelming at times, but wonderful.
What was our tour guide's background? She's incredibly knowledgeable.
Oh, yeah. Sarah Manny is our CNO. She's our chief nursing officer here at Connecticut Children's. She's a HEMOC nurse by training, but has been with the organization for many years and has just kind of walked through each of the different spaces and done quite a bit. But the build was really all encompassing for the leadership team. They were all involved in every facet of the build.
I was telling her everything is so intentional.
It is so
And I think it's so beautiful because you can tell the feedback was not only obtained,
yeah,
but then it was taken into
heard.
consideration,
Right.
and then
Right.
enacted on. I think that's just so beautiful.
yes,
Like the elevator to go to like the MFM, like that is
Yes.
incredible to me.
yeah,
Yeah, that
right.
makes complete sense.
Well, and the concept of not having to walk through the children's hospital and hear baby cries as you're walking
Right.
to a delivery that has a lot of uncertainty, obviously, if you're delivering her. And so all of those pieces,
Yeah.
openness, the outdoor spaces, that, my office is windowless, but with intent, right? We're on like little windowless offices with intent, so the patient runs. So they've done a lot, they've done a beautiful job. I will say I'm working on the Ronald McDonald project. It was a complete passion project. It stems from one of my palliative care patients was highlighted as the Kentucky child of the year because he does rehab there from an ATV accident. So he was spending his summers living there and they loved the family so much that he became the Gala family. And I was like, why is my child a Gala family in another state? Like, what are we doing? Why is he my child? Why is he my Gala again?
Right.
So there was some, there used to be some stipulations about multiple Ronald McDonald's in the same state, but we are the last freestanding children's hospital without a Ronald McDonald's house in the country. So it's happening. So I'm very excited about that concept too, because the thought of that fetal care patient being able to go across the street and be with their children, have a dinner in a normal place is pretty extraordinary. Or the opportunity to take your child to a different space for dinner and such at the end of their life is just really beautiful.
I didn't even know that Yale had 1 year.
So Yale has the Ron McDonald on site. And they've done some renovations there, and the other place is Bay State, so Springfield, because it's the two states together.
Oh, okay.
So Bay State, which is smaller hospital systems, have them for that. But we thought tooth and nail, and now we're really excited about it. And the opportunity brings, and I'm not kidding about volunteers, right? I'm not kidding about, it opens doors in a way for people in the community to become more involved with Connecticut Children's.
Yeah.
I mean, I'm of course already like, well, there'll be a food pantry and there'll be and they're like, easy now, lots of there'll be a book room with a book nook for exchange. And they're like, okay, great.
Right, so that's great. That's
a lot
great.
of growth opportunity, but all the work we're doing is part of that, right? It all goes together of if we are able to provide children with more palliative care options throughout the state, then we offer them opportunities to live better with more quality of life, and then we use the environment we have here to support them.
I just have one question for you that, isn't really for the meeting, but I'm always curious, how did you get into
Oh, sure.
like pediatric oncology, which is,
It's interesting, that is the third time I've been asked this question this week, which is interesting. My first time was I have a teenager with leukemia that's been in the news a little bit, a football player, but his family sat me the other day when I was explaining his transplant steps. They said, we just need to understand how we got you and how you came, so we went through this whole story. And then I had a student shadowing me at the University of Wisconsin, and she had the same question. So the third time. So I always knew I wanted to be a doctor. If I were not going to be a doctor, I would have taught first grade, because I thought teaching children to read would be the second best thing I could do. I wasn't going to be a pediatrician. And I always thought that I would be a general primary care doctor. And I loved adult medicine as much as I loved kids. I didn't mind CHF. I didn't mind none of it. I loved it all. So I did internal medicine and pediatrics. And after 4 years of being on call every third night, I thought the thing that made me jump out of bed first and foremost was a new cancer diagnosis. So I sat with it for a while and decided that's where my time was. And then in terms of palliative, I don't feel like that was a choice. I feel like that was a calling.
Right.
I feel like it shows me a little bit where I was like, 85% of the children I need are gonna survive, and then the other 15%, I'm probably gonna do my most beautiful work. And that has been true. So that's how I got there.
Okay.
Alright, we're so glad you guys are here. So
Yes.
without further ado, let's get a report ready.
Let's get our report ready. All right, what do we want to do? How to,
Would you like me to start things off?
yeah,
So, let me just say, one of the things I'm not sure it's been completely clear is that we've already been given permission from the assembly to proceed ahead with this. So I don't think we need to justify anything with too much data. I think we need supporting information, but they've asked us, what do you expect to do and how much funding do you need from us? And I think in addition to funding, what type of support? So I think if we proceed ahead with a written report, we should go into it with that understanding, is we don't need to come up with documentation to say this is why, because they've already said we agree, right? I think also just getting clarity on what it is that we need to build out. And Jessica was very kind to, on our last call, to talk about over the next period of time. The next period of time is probably the next year to a year and a half. We're developing a framework for a future program, right? And the program could be a pilot, it could be a full-out program, but I think we're building something over the next, 12 to 18 months that could be launched in theory. So I think we need to think about the steps that it's going to take in order to get us to that first tier of moving forward and actually actionable steps. And the report I put together, and I think the little agenda I put together has some of those things, but
somebody speaks it in your book. I'm sorry.
I'm assuming that I just wanted to make sure we were clear that our efforts right now are building components so that we can take action on something.
Can we just clarify
Yeah.
two things? Okay, one thing I want to clarify, and tell me if you're with me on this, is we were originally charged with developing a pilot program for education, nursing education. That was like the pilot program. We were going to pilot, how are we going to get nurses trained and so on and so forth.
Well, I'll correct you on that. The report that the assembly approved last year gave us a list of things that they had already approved. Let me just see what they, one second, I'm sorry. Let me recap that. Sorry. Yeah, our working group mandate, the bill 1540, which was approved last year, basically says that we'll have a pediatric palliative and hospice care center of excellence pilot, recommendations on appropriations, operational requirement, education standards for nursing, and any necessary licensing or certification. So they already said, yes, this is what we
Where
expect.
am I getting that? The center of excellence was going to be education. Am I?
It was
not-
expansive beyond that. I think it was
Agreed.
inclusive.
Where's my-
Agree.
I need to go.
Yeah,
I think
so what they approved was inclusive of the nursing education piece, but it was really more having a center of excellence to run something, to have certifications and licensure.
Okay, so that makes me feel a lot better. Because I thought this whole time we had to prepare a pilot program or a center of excellence where nurses could go and train for pediatric hospice and blah, 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 blah. That's why it was making me a little nervous that we have not done that. However,
Right.
With your knowledge of informing us that there has been now kind of a criteria made for the curriculum, right, in nursing for this. That makes me feel better because that's work we don't have to do, right?
Mhm.
My second comment that I want to kind of throw out there before we dig in like page by page is what we're putting together to me. Also, when we say money for,
Mhm.
we need to, if we're doing champion care, we
Mhm.
need to be able to run champion care, right? And what would that look like?
So I think before we get to running in champion care, we need to build out the framework and elements
No.
in that framework.
Yeah, totally,
Yeah.
totally get it. But when we even talk about champion care and we look at what we need funding for,
Right.
we're not looking to build champion care to be the house of the nurses that are gonna go out and provide hospice care or anything like that. We're looking for champion care to be the overarching, this is where you're gonna go, family that needs hospice or whatever, and we're gonna direct you to where you can find those things.
Mhm.
But we're not going to employ a nurse who's gonna provide hospice care.
I think that's a question.
Okay.
Yeah.
Well, that's a down the road. That's a huge funding.
I mean, that's a, yeah.
is,
'cause
but I think it, so I think we have to put in the back of our mind, I mean, for example, your program, do we need to fund education for some of dedicated nurses for at least the early stages in 2027, to have dedicated nurses to do something, right?
And
So
I
these-
also
these
want
are
to
all-
recognize Barb up there.
Yeah,
too,
these
but
are
I
all
know why we
questions,
want-
so.
Right, all the
Yeah.
questions, but good things to kind of, throw around, because I don't want the state to think that we're suggesting champion care. They're taking care of the kids through champion care, like they need to hire nurses, no. But champion care needs to be able to tell either hospices and palliative care that, this is how you're supposed to be you should be
Mhm.
doing it. Or what, okay, I just wanted to clarify that, but you wanted to,
It looks like Barbara might have a question.
yeah, I was gonna say, I don't know if she has a question or comment.
I
Barb, you're-
actually have a comment. So Tony Ann, I don't think you were wrong when you indicated you had something in your brain that referenced in the current legislation, the Center of Excellence pilot program. So Melissa, in the report, you did put an excerpt from the Public Act, and you did include what the requirements are for prior to July 1, 2026. So it does say that on and after March 1, 25 and before 7/1/26, the working group shall be responsible for developing recommendations for the establishment of the champion program, comma, a pediatric palliative and hospice care center of excellence pilot program.
Right.
And as described in the report, and then we have to, within those two requirements, contemplate, and Peter, this is where we may need to look to you, appropriations necessary to establish such program and pilot program, and then requirements that the program will need, education, and then any licensing and certification. So we can't lose sight that there has to be a focus on that Center of Excellence program, Tony Ann, that
Right, okay.
you mentioned.
Right,
So your
okay.
memory was not bad.
Okay.
I think
No.
there's a reset I'm sorry, go
No,
ahead.
you please go ahead.
There's a reset that we have to go back to the assembly, and I don't know how you say it aloud, or if you just redirect that we are not going to be giving them a pilot, right?
Right.
What we're giving them is
The
a
rest.
goal, a framework to develop the recipe to have a pilot. So we're kind of taking it a step, we're pushing it off a bit.
See, but I don't, and so this is where I'm going, and this is why I love being in person, because it's so much easier to then say, okay. I don't know that if we're giving them a recipe for champion care and what that should look like or how it could look, that we could then pilot that. I don't, yeah,
Without.
I mean,
Right.
it would be, this is what champion care should look like and is, and we're either establishing it or we're not, but we can't pilot it.
Right, and I
Right.
don't think we're not ready for launching anything.
We could
We have-
pilot the center of excellence in the education piece of it. What, I mean, I only remember this because I sat specifically with Senator Anwar and he was like, okay, we need a center of excellence for education. But where are students going? Where are the students coming from, number one, and where are they going to train? You know, or, you know, go through, seeing hospice or palliative care for pediatrics. Eileen.
Go.
So this is extensive work and many minds. It's incredible. I just want to acknowledge that so much has gone into this. And in reading through it, I took a lot of notes and I was a bit confused in points.
Mhm.
So when it says Center of Excellence, is that to be regional?
The Center of Excellence is a place now. When I first met with Senator Anwar, he's like, could you be a center of excellence for training nurses in pediatric hospice and palliative care? Yes. What I said to him at that time was, right now, we work with.
Okay.
And he said, so could they send students to test your training? That's where the pilot came from for a center of excellence.
Okay.
Which, you know, we could do or set up or, you know, whatever.
Okay. If we could hold the whole education of the workforce, just hold it for a minute. So when we talk about champion care, that's more at the Medicaid level. Or
At the
it's
state
government
level.
state level,
Right.
right?
Yep.
Okay. So,
That doesn't even include education of nurses to me. It's how we're gonna run
yes.
hospice or
Okay.
palliative care
Agreed.
services. Yeah,
Okay,
yeah.
I feel better about that.
Yes. Yeah,
Because
yeah.
I thought it was gonna be housed at regional. In some part here, I just thought, hey, regional is one part.
Right.
How's the rest of the state gonna receive this care?
Right.
This champion
No,
care?
that's not about care. That's about regional has agreed
Okay,
as one of, if not the only hospice that's doing pediatric to help train nurses.
okay,
That's the only part. Champion care to me. And this would go back to Barb.
Yeah.
Should be. And I don't know how to say this and how this would be directed, but if you're licensed to do hospice. And or palliative care, you should not cherry pick. That you're not gonna do pediatrics, you're only gonna do adult. I think we have enough providers that. Maybe there's certain criteria that you're gonna do pediatric hospice, maybe there's certain help that you might need in training or other things to ramp up to do pediatric hospice. But the entire state needs to do pediatric hospice. We cannot take on what we're turning people away because we don't go to certain areas. We can't. So champion care to me should be running. I mean, we're still gonna get referrals, right? We're still gonna get calls and referrals, but overarching. It should feed up to some repository that's then gonna say, oh, you know what, you live in Branford,
Yes.
Connecticut Hospice is there and they
Yes.
do pediatric hospice.
yes.
Oh, you live in. I don't know Connecticut that well, but you live in somewhere
side of the
else. Downtown over the river. This hospice actually
Yes.
provides pediatric.
I'm on the same page.
Yes, the
Thank you.
center of excellence to me was only that we were the only ones willing to train in pediatric hospice. When I met with Senator Anwar.
Okay,
I'm also thinking that a center of excellence starts here and then over time expands, right? That the more organizations that are certified and licensed and skilled, they become part of the center of excellence. So it's a concept rather than a physical organization. It starts out as a physical
Well, it's
organization.
something you need to achieve. You
Yeah,
you cannot
yeah.
just be a center of excellence. I could provide not good pediatric hospice and say I'm gonna be a center of excellence because I'm gonna train nurses. I think there has to be criteria to
Right.
somewhat be, right, a center of excellence for training.
I agree with that too. And I was concerned about the Center of Excellence. I wanted to clarify that for the position.
That was actually his wording.
Okay. So someone else said to me, why not call as regional, say, surfaces to the top, then Branford, then someone else, why not have a circle of excellence? For consideration, I don't think it needs to go into this report, but
Yeah, I
rather,
wouldn't put it in the report only because as we talk to other hospices, they don't even have pediatric nurses.
right.
So,
So now to talk to education. When we had the initial conversation a year and a half, 2 years ago
Right.
about could students have a longer transitional exposure? Yes. Can I make that happen? Yes. That was under different leadership at Fairfield.
okay,
The current leader still on board,
okay,
but between that period of time, I did research and I did not have a well-informed understanding of how desperate families are in the community across the state.
right.
So in looking at that proposal, I was proposing maybe 2 or 3 students. They would be undergrads. They can't go through certification without work experience.
Right.
So they would have to graduate, spend 2 years or so in the field,
Mhm.
then seek certification. So maybe over the course of 3 to 4 years, Fairfield has 1 to 2 students, new nurses.
It's a long term. It's a,
Mhm.
so the
So I
education
was
piece of it.
having-
So the education piece of it, right?
This is not gonna meet any demand.
No, and it's not going to. What we're looking to do is for the future, how do we get nurses even looking at or seeing or getting a taste of
Exposure.
pediatric hospice and getting what really as a center of excellence, we should be doing regional hospice, which is what we're trying to do, and what we're doing through the palliative coalition. How do we educate existing nurses
Exactly.
today?
Okay.
How do we take the nurses and say, come to this symposium, let us train you, let us give you little bits and pieces of this so that the active nurses can start getting trained in pediatrics.
I couldn't agree with you more. So I would like to propose that Fairfield be taken out in that proposal from 2 years ago.
Totally
To
totally
develop
agree.
a workforce, it has to be the workforce, in my opinion. Has to be the workforce who's doing the work right now and
Correct.
needs pediatric
That, yeah,
education.
that, and I'll say immediate, meaning the next 3 years. There have to already be nurses.
Yes.
There are nurses who are gonna train in
Yes.
pediatric hospice or palliative care and start helping fill the gaps that are there. The beautiful thing will be when nurses are now in their nursing program to get a piece of death. The hospice, the palliative, the pediatric, that they may say, you know what, I wanna go into this.
Okay.
So that's the longer term kind of thing, but the shorter term is how do we get nurses now, boots on the ground, trained?
Taylor Aglio.
Yeah.
I'm trying to get an appointment with her.
Yeah, so, can I just pause on that for a minute?
Yes.
I think so much of this is less dependent on us and more dependent on the legislature. Like so much of this that we're talking about and where we're going is really directly to respond as to like how much does the state want to invest in this? Because if they come back and say there's funding, then all things are possible. A state program like PD Pal in Massachusetts is possible. If they come back and say funding is not going to be a priority in 10 years, then that's a very different vantage point. So I kind of feel like some of this conversation is really beyond what we control. Like, and
Absolutely.
and
The whole
so mu-
thing, I think, is
right,
beyond.
because I mean, all of this work that we've done so far is unfunded. And we know like, right, so at what point does the unfunded piece end and we say, well, we're not funded for this work,
Right.
so if we're gonna continue it, there has to be some sort of allocation. And then that
Yeah,
either turns
and I
into
agree.
a pocket of money, or that turns into a programmatic structure. I'm not sure which way it goes, right? I think that this is the right idea, but possibly the wrong time financially, who knows?
And that could be, but without that, then this is nothing.
Well,
And we
it's-
go back
I
to,
would argue it's something, but we have to go back to how it becomes more of a, so I think when we think about it, the legislature has no idea what the coalition is doing, and the fact that there is now a coalition, right? There's been so much growth in pediatric palliative care within our group, within what we've done, but also just around us. And so putting all of that together in a highlight in itself was enough for them to say, wow, this is a priority in the state, but they need funding, or they need direction, or they need.
so this is where I go with palliative care, and Jessica, you help me out here, or, correct me. For me, I think palliative care is a wonderful thing, but to truly take care, right? For an agency to do palliative care. The funding would have to be exorbitant.
Correct.
I cannot provide palliative care
In the way it deserves to be provided.
in the way
With
it,
reimbursement.
not only in the way it deserves to be provided, but even if I provide it in the way I think it should be done. I'm billing for one visit a month and a visit for a social worker. We can't sustain that.
Right.
So that's where, if we're talking about funding, and that's a whole different thing that would have to be figured out, and I don't know,
No, I think that's the beauty of concurrent care, and the reason that there was so much advocacy behind it was that it allowed families to have a degree of the palliative care experience, be able to not call it hospice, but still get the proper amount of reimbursement and the proper amount of visit.
correct.
And so I think that, and honestly, if we also just look at the purpose of palliative care, certainly there are children that benefit from palliative care that will have a very long life. And
100%.
will go into adulthood, but there's also the understanding that palliative care is that bridge. And if we don't have a firm foundation of where the bridge is leading, then we also are setting ourselves up to create this beautiful bridge of support. And then once they're ready to transition and get to the other side and really experience end of life care, we won't have the mechanisms in place to fully be present for that.
But isn't that what we're saying champion care should be? Aren't we saying palliative, hospice, champion care? You have a chronically ill, you have you have a child that maybe is not going to die in 6 months or less, but needs your services. What does this new service look like?
I've always, I guess my perspective of champion care and reading through everything is more of an umbrella term.
Right.
We are defining the care that we want to offer throughout Connecticut to children as champion care, being focused on advocacy, patient family experience. We want to make sure that their symptoms are being managed, that they have all of the emotional support that they need. And within that umbrella, there's like all these raindrops of potential options. We have the option of end of life care. But we also have the option of concurrent care. Well, we don't know what concurrent care is. Well, it's a good thing we have champion care to explain that to you and
Right.
be able to really walk that path with you and help make the connections, because everything is so segmented in healthcare and it continues to be segmented in healthcare. So how can we help with those gaps and be able to say, oh, well, I have a great relationship with this wonderful palliative physician, Dr. Moss. And I know that we could probably find a way to help support you in the hospital. And this is how it's worked at Connecticut Children's, is that your typical hospital you go to, okay, and then at home, oh, you're looking for extra support. Tell me about what's going on, getting an idea, oh, so you wouldn't quite qualify for concurrent care. This is really what we look at for qualification of that. Here's something, since we don't have palliative care, or maybe there will be someday, this is what we can offer right now. And these are the things to look out for when you think you might be ready. And here are the providers in your area that I think that's almost like the image I got in all of the conversations that have been happening and even reading through this. It's like this umbrella with all these different potential things underneath.
Correct.
And I saw the Center of Excellence being almost like an accreditation of some
Right,
sort.
yeah.
Right.
That you have shown that you provide such great holistic care for children at end of life, that you can now be a center of excellence, and that would be a term that could be passed on.
And that's what I think is a thing that's achievable, right? You
Right.
would have to achieve that.
Right.
However, where I struggle is if we're going with this, we need more providers. So
Exactly.
you may not become a center of excellence,
Exactly.
but how do we get more providers to provide pediatric anything? And at the end of the day, when we do say, okay, champion care, who's providing palliative care? Other than you all here, right? What agencies, they're not even providing pediatric hospice, are providing pediatric palliative care in this state?
Yeah.
None, because it's not sustainable.
Yeah.
So that's where I try and go back to champion care. Part of building champion care has to be a recommendation that palliative care somehow, some way, reimbursement has to change. I mean,
That feels federal, doesn't it?
it definitely feels federal.
And it's
So Barbara has a question, but this might be the
Oh.
right time to have our colleagues here
Or-
jump in.
So I just wanted to kind of bring us back to the problems we're trying to solve. As from the very early Genesis days, the two problems I think we identified are there isn't adequate access to services for children who are living with either chronic progressive frailty or at the end of their life. That was number one. And then our solution was building the Champion program. That would be, as Jessica, as you've mentioned, the umbrella of services. The second problem was, well, we want to build this big program, but we don't have staff. So the Center of Excellence was going to train those staff. So we want to stay focused, I think, as we move forward, at least on our recommendations on those two problems. And the reason I bring this up is because the legislature will need to know how much this is going to cost.
Right.
And one of the ways we need to identify that is, and they're going to be two separate buckets of money. One will be for training and one will be for the Champion Care program. And while Tony and I don't disagree with you, we have most home health care agencies / the 28 hospice agencies that are not providing pediatric hospice care. I think it's because of the educational piece. What I'm hearing on the ground is they just don't have the trained staff to do it. So the Center of Excellence, or if we're going to call it a Circle of Excellence, that concept will maybe move that ball a little bit further, where we have 2 or 3 hospice agencies now that provide PD hospice care. If we can increase training, maybe we could have 10. Maybe we could have regional centers that are providing it.
Right,
So-
and that's one of the things I think, in order to provide champion care, we have to have, like you're saying, more hospices doing. So even if the Center of Excellence, but we had a perfect thing set up with Day Kimball, right? Now, she's no longer there, and they have decided that they really can't they only have like 25 people on their adult census. But Day Kimball was we'll send nurses down, because at first we started with just pronouncements, send nurses to regional, get trained, so at least we could cover those up in the corner of the state, wherever Day Kimball is. And then that kind of fell through. So yeah, I agree with you 100% that even if there are agencies that are willing to train nurses, that would be perfect.
And I think that's where there would be value in the Center of Excellence program in doing a pilot and working with maybe 3 or 4 agencies and identifying, well, we've done this with 3 or 4 agencies. Now here's our after action report after we've done this work. And to your point, Eileen, we may say in the after action report, we now have identified that this needs to be a circle of excellence, not a center of excellence. But then we get back to the appropriations that we're going to need to do that. So we will need, and Dr. Moss, you were asking if it's federal or if it's Medicaid. Medicaid will want to know for the Champion program if there's a fiscal note for this and how many beneficiaries could potentially be affected. That's what will help with formulating the fiscal note for DSS, is the scope of children that may need to scope children / families, because there's a whole constellation of services that could be provided. How many of those families are involved, and how much will that cost the Medicaid program? That's where it will be essential to have numbers.
Right. Just as a sidebar, is this something we can pull together for this upcoming report, or is this something we're going to need to build out over the next year?
Can I pause and think about that one? I think
Sure. I think we may need more time, frankly, but I don't know if this
needs
is.
to get into like an MOU situation when it comes to like talking about Medicaid and what, who's covering what the payment's gonna look like, and that takes a long time and a lot of conversations.
Yes,
I
it
just
certainly does.
other people knew the numbers. So.
No.
Maybe if we can pause right now, have your colleagues talk to us about the parameters of palliative hospice care, and keep us in check with those things.
Because we've got a little slide deck.
We do have a couple slides, although I'm wondering whether at this
We send them
point,
to Peter, if you want to do it that way.
we could do that. I'm also thinking that maybe we could just briefly just introduce an overview and then pull up the slides later if necessary, just to make
Yeah,
sure that
sure.
we don't disrupt the flow of the conversation too much. And this is where I'm gonna invite Jeremy also and Eugene to pop in whenever. We talked about this before, and so that's why I'm gonna start talking, but they will potentially talk as well. So just what we would just like to talk about is, well, first I want to offer a very large apology on behalf of our entire profession. Because as I'm sure you're all deeply aware, lawyers just mess everything up. They come in, we're just like, what about this, what about that? But if you define it that way and put it in that bucket, so I'm really sorry. Because a lot of what we've been talking about is confusing and complicated because of decisions lawyers have made. So, sorry. That, and then other lawyers we're here trying to unravel. Just to the point about just trying to separate out what needs to happen at the federal level from the state level. Is so 2 points. One of them is that I think that we're all on the same page, just to clarify, just from a legal perspective, unfortunately, in order to fully integrate palliative and hospice care, where, to make something like champion care into like its own thing, where the distinction between palliative care and hospice care is entirely clinical. So it's entirely something, a conversation and decision that would take place between a child, their family, their care team. That would require a massive change at the federal level for a couple of reasons. One of the big reasons I think we're all familiar with is it's the way that Medicaid is structured. And there are certain things that the state can do. The state can go, hi, federal government, like we would like to reshape our Medicaid program in a particular way. But there are other things that states really can't touch. And one of the things that states can't touch is the way that the federal government regulates hospice. And because at the federal level, there's such a strong emphasis on not just end of life care, but putting hospice as kind of a separate thing. It's separated a bit from other types of cares, as you all know much better than I do, but just in terms of the legal status, is there's not a lot of wiggle room in there, despite what we can see with things like concurrent care and with things like concurrent care's definition. It looks fantastic. It looks like, yeah, we can just introduce this early and we could just like make it available for everyone. But to really do that in a way that would not invite litigation and would not freak out the legislature would really require a big change at the federal level. It would require changing potentially not Medicaid law, but would require changing Medicaid regulations at the federal level. So, and I think that's why if you've heard all of us, at the Solomon Center talking a lot about palliative care, we understand that it's really not feasible for a hospice agency to be taking this on. What we're trying to figure out, again, from our limited legal standpoint, is to what extent can palliative care outside of hospice serve as a gap filler, which would require other providers, we understand. But we're thinking about this just because, unfortunately, federal law does create these hard limits on what hospice care can become, because that really wonderful, not all the time wonderful, but that per diem, which does provide a little more flexibility, especially in the concurrent care space. The federal government's like, yeah, we don't really want people playing that to And we don't really want you to do something that we can label as you doing something that's not hospice. And so when you enter that gray area, that's when all the lawyers get involved. And so even though up front, it seems like, at least I think it seems like so much easier to say, just like, palliative care is wonderful and useful, put it off to the side, it's something separate, but it does have to be part of this conversation because in the long run, it gets less complicated if we are doing this kind of Frankensteining, trying to put together an EPSDT benefit in palliative care plus some sort of expansion on hospice. And I know that all sounds really legal and it sounds like, why are we dealing with these things? And so try to wrap up my ramble is just from what we found in our research is that there's a very close connection between workforce expansion and funding reform. And so we think from, again, just the legal side, what we were seeing is that if you wanted to do something like scholarships, if you wanted to do something like a center or circle of excellence, is that the way to sustain that over the long run would probably be to pair it with some sort of funding reform, which would look like turning to Medicaid and trying to see if there's one of the things we've looked at and think we've all discussed is one, trying to formalize a pediatric palliative care benefit, and that would be for outside of hospice. But the point of that sort of thing would be to sort of just make it a little bit easier for existing pediatric palliative care providers to do what they're already doing, and also make space for hospice to grow in a way that's not going to freak out federal government or state government, because then you would have two separate distinct benefits, but they're in existence. It's not, well, we're going to piece together this palliative thing and then there's hospice. It's like, well, they're two distinct benefits and then please leave it to the clinicians and, you know, hospice management, hospital management to decide how they're going to bill. I don't know if that makes sense, but just so it's building a foundation and it's kind of picking you know, complicated options that are going to take some time to build. But I think, but laying out, you know, for an expansion of hospice specifically and trying to get hospice providers, retraining existing care providers. We think that the kind of payment reform that would most match that, kind of two options. Is that one would be looking at the hospice eligibility and not getting rid of it fully because it's probably going to be unfortunately a non-starter with the lawyers, but moving it up, which is something that we have seen in New York. And then that's again just to ease this and make that bridge.
When you say
stronger.
moving it up, you mean like make it a year?
Make it a year. A lot of states do a year.
Yeah, these, I think something like that, that would be a spa, that would take a long time, but that might be something that would be worth piloting with a waiver. Not sure, would have to go talk about with other folks, but something like that would just give providers more wiggle room and it would kind of keep the lawyers away. And then that might create some space, but then you'd be able to use that level per diem.
Can I ask a question? When you say it takes a long time to create that, what does that mean time wise?
Probably a few years.
Okay.
And I think that's something where, that's a group like this would not be in charge of that. That's something the state would probably want to do on its own. I think some of us might have seen, I think I've never been part of it, but I have colleagues that have been part of this, where it's another group constituted. It's more interior to the state. It's something that, you know, their Medicaid folks are going to be looking at. And so that's not something, I don't think this group or any other group that's similarly structured would be on the hook for coming up with, you know, the nice details of billing and other things. It would just be presenting this as an option, just saying, you know, hello, Connecticut, this is something you could do. And then kind of stepping back and letting them work out the details. So
Well, is there an appetite federally and nationally to make that happen?
So I think this is where I probably don't have the expertise and I'm not as far into these conversations nationally, but I would say for expanding, for changing hospice eligibility in the state of Connecticut, is that would be something that Connecticut could do. It would require putting together an application to the federal government, which is what this big, long process would, that would be centered in the state house and the state would do. That, couple-year process, but that would not require any changes to federal law. It would not require any changes to federal regulation. What it would require is basically asking the federal government for permission. And I don't think anyone could guarantee that the federal government, as it currently exists, would be completely on board. But the way that spas are structured, is that it gives states a lot of flexibility within them. Because it's interesting because it seems like you don't have a lot of flexibility, but you do because they're very highly structured, which means that there's less discretion that the federal government can exercise. Is this if you go in and you can show a couple of things that are hard to show, but show that, you know, for the federal government, it would not cost the federal government more money. A couple other things just showing that, yes, you know, care is high quality, and once you lay that out, the federal government has the last room to say, this is not a policy priority. And then, I mean, fortunately, for this work, I mean, I think it's gonna be harder for any government to say, well, we don't really wanna make sure that very, very ill children are getting the care they need. It's a little bit harder to say that, you know, we're gonna stand against children and their families who are really ill.
Wow.
I know it happened. I know it happened.
To say, I mean, I will say, like, just speaking from like, the Affordable Care Act is, tender right now.
Yes.
And I think anything that's going to be just even related to it is something that is like on the back burner at this point. I
Yes.
think we're all kind of waiting on bated breath just to see what happens in the next 3 years.
We're hoping
then-
nothing happens.
What?
We're hoping nothing happens.
We're hoping nothing
Right.
happens, but I think even, you know, drawing attention to it, people are really trying to avoid. I think, you know, keeping things as, just keeping things as quiet as possible is something that a lot of other like programs in the states are really doing at this point. I mean, you're not seeing a lot of legislation even go through about like licensing for complementary therapists right now, because they're like, we don't want to rock the boat any more than we have to. I think what makes, and we talked about this in like the first meeting, concurrent care is so hard because they gave us this big, beautiful thing with no idea how to manage it. And all of these holes and loopholes that we could work around, which I know attorneys really love. Not in that, not. in
Not
that
all
way.
of us.
If you're kind of fun, it's like solving a puzzle and you're like, I found this. But I think that allows us to be able to provide care, but I agree. I think if we go too far on that, it does open up liability. And the question of, are we providing equitable care across the entire state? Are we providing care that's ethical because we're following the regulation the way that we should? And then it all comes back to, how are we actually even providing this care? Like before the palliative care benefit could even be explored, how are we providing care to kids that currently need? And
I got a funny question. Well, first and and I thank you so much.
Yes,
Because that
thank
was
you.
amazing.
And they haven't finished their.
Oh, no,
piece, right?
No,
Yeah,
it's
yeah.
fine, but I'm just, no, I just want to make a comment right now, first thing, and I need to apologize too, because I did not introduce Beth Meyer, who is our pediatric nurse. Case manager at regional and.
She's like, what did I get into?
Yeah, no, and I just thought that, you know, if she had anything to throw at us at the table, I thought it would be good that she was participating, so Beth Meyer. Task force.
A very passionate.
Yes.
But sometimes all over the place, task force.
Yes. But here's my question, as I'm even thinking myself. As I say it myself, I get on the fence, and as you said it. I'm gonna ask you, I'm gonna ask you, and I'm gonna ask you. If the criteria was 6 months or less or a year or less, do you think that would change when a parent is ready to put their kid on hospice or not?
It might change a parent, but it might change a referrer.
It's gonna change a provider.
It's gonna change a provider.
It's gonna change a provider, okay.
And typically the
Okay.
approach, you know, we take, and a lot of people take, I should say, is. If we were to remove all of the concurrent care intervention, is there a likelihood that this patient could die in 6 months or less?
Right.
And that just puts a lot of pressure on a provider. I think it in some ways makes you feel a little bit better because it's like, oh, well, I feel that opens it up quite a bit because we could all die in 6 months
Right.
without like prolonging intervention. If I stopped eating tomorrow, probably wouldn't, but so it has like a duality there, right? Because it makes, I think, people feel more comfortable, but it also puts more pressure to say, well, what happens if it doesn't happen in 6 months? And that's where the hospice team then comes on board, and then that's where the pressure kind of gets changed.
Well, if
it's a
they're
year,
but if they're even
that's not
called
gonna
in at that
change.
point.
I don't think. I mean, I think it would make people more amenable to
referring.
Yeah.
I think.
But the
it would, absolutely.
pressure is still
If-
there.
A year to 6 months feels huge as a provider.
Yeah.
Refer.
Okay.
Feels huge. A lot happens in a year. And
Okay.
6 months feels more like we're looking at we always talk about
Seasons.
days, weeks, seasons, right? When we put all these things together, a heck of a lot can happen. But we say, well, maybe you're at Christmas, like that's always feels really, it feels really prognostically accurate. Like and it feels sometimes dooming, right? Like, well, so I do think that would change my sense, and I think it would change others. And as parents, some of what parent senses is based on the comfort of the provider explaining the process. So I do think by default, parents would be, as a secondary effect to the provider. Because, I have parents that are gonna do whatever I tell them to. I just wanna make sure I'm telling them right.
Right.
Right, they're gonna follow the lead the journey they're gonna let me lead and they're gonna follow. And so I wanna make sure I'm leading in the right way.
And I don't mean to put you on the spot,
put
but
me on
you're
the
the
spot.
only physician here.
Please.
When we look at concurrent care and we look at that they can come on hospice and still receive all of their
Things.
Yes.
life belonging things. Is it still the wrong thing? Because we're not coming in and ending their life. We're just coming in and supporting them through the process. So if we did better in educating, right? Or changing the conversation to, like you say, and this is where I always go. If we did nothing from today, your child would probably die in 6 months. That to me is like, but we're still doing everything. So it's almost like
But that concurrent care is finite, so that, we're doing concurrent care, but. In the parents' eyes, that could last 3 years. We
Right.
know it's a short term, it doesn't last that
Definitely.
long, so we
Right.
know they're. Transitioning really into hospice care pretty quickly.
right. Right.
So we're not, I don't feel like we're taking away any, like, if we were to take away that concurrent care piece, like, the child is still declining in the same trajectory that they're gonna decline.
Right. But I'm saying to make it easier for a parent to think about hospice. If it was more of an educational thing towards. Like right now, we're doing your child's on a vent or a feeding tube or whatever. If we stopped that. Your child would probably die in 6 months or less. That's the truth. But we're not stopping it. So we're not asking you. I get confused between like when it's
This is
that
the world of
concurrent care.
concurrent care.
It
This
is
is the world of
so-
concurrent care. I mean, I agree with you. I think a spa to be able to increase that would make such a huge
Yeah, I think if we
difference.
could do
And
the year,
it has. In New York, it has, and it opened up also for providers, as hospice providers, helped them feel better about what they were doing as well.
My sense is that in the adult space as well, this has been a long time coming, because that 6-month eligibility requirement was, based on, an older understanding of, adult oncology patients, and even for them doesn't really work well. At least we do some work at the Solomon Center, with elders and with long-term care, and in that space as well, we've seen that it really doesn't work for them either, because what do you do with someone, who has one of the rapid dementias, and they're declining rapidly, and then how often do you recertify? So I mean, part of this too, I think, is just structurally, we all need just integrated whole person care. Where we don't need to make these, we lawyers do not need to be involved in these decisions at any level. And since we're not there, we were thinking, is that something like that, also you even have to mention. Yeah, you just say, this is what we're seeing on the ground, this is what providers are seeing on the ground. And it creates more money for everyone, because it's more, administrative hurdles, more logistical hurdles. So this change would just be accepting reality. And once ACA, we don't have to worry about it.
Does it help that we have precedents in other state? Like, because other states have been able to agree
Yeah,
that are next door, does that help the case at all?
I would think so. I mean, I think I have never gone through one of these processes. For what I've read, it would. And this is where, and this might not be the right conversation for this time, and I don't want to put us on a tangent, but just for the palliative care component of this, one of the things I think we've seen in our discussions with folks in other states is that although acknowledging that palliative care as it currently exists for pediatrics can be limited by reimbursement. It also can be limited by, this really complicated web where it's just like, if you have a child and you're really not entirely sure, there's no like ideal champ care where it's just like, this is just a clinical decision, all the providers are there, don't worry about billing. In the world that we live in, it might potentially help bolster, and I love that image, just, it's not just the bridge, but also it's on the other side, but just having that bridge and making sure that that bridge is stable will actually help bolster hospice care and bolster concurrent care. Because there's more of, honestly, it's just that all the lawyers and all the politicians will have the language necessary to understand the space, because we are naming palliative care by saying that there's palliative care benefit, and that can exist alongside and together with hospice care. And I'm wondering whether something like that would also add some clarity for concurrent care, because then again, there's more language for the non-clinicians and the non-providers who unfortunately are involved in these decisions at a higher level, to really be, just to give them room just to kind of disappear and just say that now there is less uncertainty with billing, there's less uncertainty with what this is, and hopefully that would give providers more flexibility on the ground. And so what that would look like, it would be like what we're seeing in some other states with like an APSDT benefit. One of the things we've looked at, I know we're discussing, is also what Massachusetts has done as a pair of last resort. That might even be a temporary option, just about like, what do we do in the meantime?
So can you talk a little bit about that you just said in Massachusetts?
So, and I think that there might have been I think there's been other discussions about this. So this is just the EdiPal program. And so our understanding, again, from the legal perspective, and I'm just speaking mostly for myself, as my colleagues have more experience than I do with these things. But and so this might not be what it looks like on the ground, but just legally, our understanding is that for the Payer of Last Resort program in Massachusetts, that means that there is going to be a suite of palliative care services inside and outside hospice. So it doesn't require a hospice, it doesn't require the child's being enrolled in hospice, but it does encompass children who require the end of life care, as well as children who may have a life-limiting illness, or they may just be in that broad category of children who could benefit from palliative care for various reasons. So those children have access to a suite of services, a suite of supportive services. If their private insurance or their public insurance through Medicaid does not cover those services, Massachusetts will cover them. We've done a little bit of research. We're trying to get data right now. It's been a slow process. As far as we know, Massachusetts has been having trouble getting enough funding.
I was gonna say, what's
we
the
started,
difference?
it used to be they were at 1 million, and I don't know that.
They're
program.
10 million.
Yeah, they're 10 million.
And they've got a wait list. Yeah, so it's like the worlds of trade-offs. So the Massachusetts world is one in which the state entirely funds the program, and basically they have entered into contracts with a cluster of service providers. Some of them are hospice care facilities, some of them are outside providers that provide services at home. And they've set their own definition of like, what is it that we're going to pay for inside of this program? And under these contracts, they're essentially per member per month type. They hand a certain amount of money to each contractor in exchange for the types of services that those contractors provide. So it's like relatively administratively simple, but it's limited by both A, sort of what the state defines in that bucket of services, and B, the overall funding from the state, which is always in jeopardy. So this is the difficulty with any sort of state funded thing that isn't a mandate, right? Like ask anybody who's at a public college or university how they feel once a recession comes around as like a non-protected item in the budget. And it's like, those are the first things to get whacked. And so it's a very flexible and useful road, but it is one of the shakier ones. And that's, as I was saying, like maybe that makes it a good sort of interim option, because the Medicaid road, which is more stable because it's enshrined then as a Medicaid benefit, takes several years to stand up. So you can imagine sort of a combo of those two things potentially. But yeah, in terms of then sort of from a payment perspective, making it more reliable over time, really your best option is going to be some version of a Medicaid reform, putting in the SPA. To the question of like, will that fly? So far, those exercises are relatively technical, and they don't, I think there's been a distinction drawn between the world of waivers, which is like states asking people to experiment, right? And the world of SPAs, which is just like, we like think medically necessary care should include this bucket of things, and our actuaries, which can talk to your actuaries, have figured out that overall it's not going to cost you more because, like, instead of going to the hospital, these people are going to go to this place over here. And so far, like New Jersey is on the verge of putting in a spa for a home-based palliative benefit that's like pretty sizable, and like they're sort of charging full steam ahead there and not acting as though that's about to just get like thrown out. But by the feds, but what are the feds doing right now? Like, who knows? No one, anybody who says they know is like lying. But yeah, in terms of the payment option, like and Elle sort of mentioned this earlier. I don't even know, and this is sort of a question going back to the report, whether this group needs to like say, because a lot of each of those paths has trade-offs in terms of time, in terms of cash. Like, I don't know if you all need to decide, like, yeah, it has to be only the spa and all this other stuff. Like, it could be a menu of options of like, these are the different ways that we can do this, and like we think these are the sort of most attractive, but over time, like, to be figured out sort of whether it can be paid for and whether it can be implemented. But there is this sort of core trade-off between the Massachusetts world of like, you have maximal flexibility because it's your program, and the like more stable Medicaid world of like getting a little bit of federal buy-in and approval, and then also then getting the funds that come with that. The other sort of element that's worth mentioning about the Massachusetts story is that they still have a bit of a geographic problem on their hands, and like I think this is essentially a variation of their funding problem, in that like they have a net, like what they've done is they've broken up the state into 8 sort of different regions, and like based on your address, like you will have a certain set of service providers that they've contracted for in that region. And like they may or may not be like that close to you, right? Like you may still have to drive it. So there are still folks who have like a bit of a tough, I don't know if it's, especially at the beginning when you're standing these types of things up, like if in no small part because of the provider shortage to begin with, like some people are just going to have to travel further than others. Like I think at first that's a baseline difficulty. Although their program has been up and running for a little while now, at least a couple of decades, and they still sort of have a version of the geographic challenge. So that's just another thing to keep in mind. The other thing from our initial research, again, we're trying to get more data from them, but the other thing that Massachusetts maybe hasn't done as good a job on, and like they're a weird comparator state because they've got their own, like they've got a much more built out statewide healthcare program than a lot of places. But they haven't been as aggressive, as far as we can tell, at pairing their payer of last resort with an insurance mandate, which states do all the time. Like in Connecticut does it all the time. They just did it for the autism therapy benefit, right? They extended the eligibility for that up to age 26. Basically, there's like a set of health insurance plans that the state can regulate. It's not all plans, it's about 50% of plans. Like there's like some private health insurance plans that fall within the purview of federal law called ERISA, and like those, like states just can't really touch those. But the other 50%, they can say like, hey, like Cigna or whatever, like you now have to cover these things also for people. And like if you define it out, they have to do it. So like with the autism therapy one was easy. Basically, there was an existing benefit, went up to whatever it was, like 21, and they just said like, now you have to cover it up to 26. So in theory, at least you could pair a Massachusetts style program with like, here are all of the services that we think fall inside the palliative care CHAMP bucket, and you non-ERISA plans have to cover that for people, and then we'll pick up anybody who's not covered by that. And at first that would also include a lot of the Medicaid population, but over time, in theory, you could potentially swap out what the state is paying for a spa-based benefit.
And not just to overcomplicate, just add one other piece to this, is that it has been a Katie Beckett working group. And so in the Katie Beckett it's like a program a lot of different states have, and as we all know, it's a way to expand Medicaid coverage. It doesn't include any services, so it's like whatever is out there in the state's Medicaid program, if you're on Katie Beckett, you get them. It's just a way that it, for families who don't have, who have too much money, that they can have those Medicaid services. And so something like this also, if there's also a way to just pair this with the work they're doing, they are suggesting, surprise, surprise, to raise or eliminate the current cap. So there's no more wait list, or it's a much shorter wait list. So something like that also could be paired with a program like a Massachusetts style program. And so, as things shift, Medicaid is taking more of that, but they're also taking more of it just through, so the federal government's paying more. But you're also being able to encompass more children. So more children end up getting on Medicaid over time as, you know, if it were possible to expand Connecticut. So the piece that, and again, that's just pure funding. One of the things that I didn't realize when people talked about the program initially is that I was like, oh wait, it's like special stuff because it's for a special group of children who need institutional level care, and it's not that. It literally is just you get Medicaid. It's just to change who's eligible from a financial perspective. So, which actually makes it helpful is it means that raising, you know, many of the children who could benefit from Katie Beckett are children with bipolar illnesses. And so the fact that that already exists, it's kind of just an extra piece to potentially put more children within the Medicaid bucket.
Can I just ask a question? I'm coming back to this report because that's
Yeah.
kind of what my mandate is on this is, do we need to define legislation for purposes of this report? Because we know it's going to take a long time to at least even frame out something that we think has value. Do we need to introduce this to the legislature? Or can we just say, we think there could be some opportunities through some legislative changes, and we'll be working on this over the next 12 to 18 months? Because I don't think we can solve, I almost feel like we should be removing any definition or any detail in this report, basically, but just talking about the fact that through legislation can put on guardrails, but it also puts on limitations, and we will be exploring this further.
One thought that I had when I saw this draft was it contrasts, at least with other types of legislative reports that I've seen, in that it's much more detailed for a report at this stage. And I wonder whether it might not make sense to like. Yes, right.
Knowing we'd be stripping
right,
stuff.
because
So
the more you give them, the more they're like, well, you said this, and then as you
Right.
learn more, you're like, well, actually, so like my sense is probably like, with the exception of people like Senator Inor, who are few and far between, who like have like deep medical expertise and actually understand the words that are being used in a report like this, that a lot of legislators like don't have any of sort of the basic concepts in their heads, right? Like they would have to look at something like this and get like a primer, like just what is it that we're talking about? And so like understanding that you can't really put all the information in their heads that they need to have, it's like making it simple on this first pass would be my inclination of, and you all have mentioned, like, to me, like the sort of core elements are on the table already, right? Of like, we know that there are these sort of like two strands that have to be in the legislators' heads of like, there's not enough access to services, both because of like payment and coverage issues, and there's not enough of a workforce to provide those services, right? So it's like whatever you do state ideally should hit those two buckets, and then inside of those two buckets there's all sorts of stuff that you could do. So I'm less well versed on the training piece of it, but like today, right, folks have talked about how there's like a temporal dimension to the training piece, right? Of like, there's some stuff that you just can't do fast, right? Of like, we need more nurses who specialize in this area, but it's like, you gotta recruit those people, train those people. Like in some cases, you might have to like get more people to move to the state who maybe want to do this type of stuff. Like that's like a multi-year endeavor. But then on the other hand, you have like a group of nurses who have some component of the expertise, right? They're already working in hospices, like maybe they're already working with kids in non-hospice settings. It's like, you could do something to retrain those people in the shorter term. And you do all of that, but you sort of sequence it in some way. So it's like, maybe that's like a series of bullet points of like, here are the types of things that you could do to try to hit a workforce problem. They'll have like different sort of temporal constraints attached to them, and they maybe fulfill slightly different functions, but like there are options on the table that like a working group like this needs to continue to explore, that the legislature should explore. And then ditto with payment, right? So it's like, for instance, the Katie Beckett thing is like, in theory at least, is a low-hanging fruit of like, here's a way to get Medicaid to kids who have income, whose families have incomes that are normally too high to qualify them for Medicaid, but it's like they have a certain set of conditions. They can get that coverage, get the hospice care they need, and like if you've taken those people out of the like, how do they pay for it quandary. And then, you know, other thing that we can do, we could do the Massachusetts thing, we do a SPA, those will have different sort of timelines and trade-offs, but at least sort of like breaking that out for them so that they have a sense of like what's possible. To the question of numbers, it's some of it you probably can't do without DSS, right? Of just like how much would a certain Medicaid intervention cost. Other stuff has been costed out. Interesting. So I looked at the Katie Beckett working groups materials. They did at some point, I don't know how reliable the estimate is, but they got an estimate because this was one of the things that the legislature asked them for. But how much would it cost us to get rid of the current weeks? 350 kids or something. And there's an answer, $16 million
Yeah.
split between the feds and the state. So $8 million for the state to get rid of the wait list. Not that crazy. How much does Massachusetts spend on its programs? Currently 10 million total. Like, I can't remember what the length of the wait list is, but you can come up essentially with a number of like,
Yeah.
There's
there's
328
it's
kids on
somewhere in the-
piggyback right now, and I think there's like close to a little over 400 in the wait list plus, and I don't even know if they know what the plus is.
Yeah. I mean, if you wanted to, again, I think it's like potentially like goes beyond the scope of a report like this, because it's partly their job, right? It's like
Yeah.
legislative analysts type job to figure out, really crunch these numbers. But there are some of these reforms that would attach an estimated dollar amount to sort of like a ballpark, this is what you're talking.
Just ballparking for them that we're not talking about, you know, hundreds of millions or billions of dollars, that, you know, we're in the tens of millions range, which even for state of Connecticut, which is on the smaller side, is, yes, I mean, doable. Yeah, it's doable. Yeah, and so that's something where I don't think we have to worry about that too much, is to like really cost out anything specific.
We've been struggling with getting numbers, just even at data, so I will tell you, it's guesswork to a
It's
certain
not
degree.
entirely
'Cause it's-
surprising, because when a state really does go down the spa road, like that exercise is high, like the accountants are coming into the room, like it's
Right,
very technical.
Right, and everybody
thing.
has proprietary approaches to things, so it's understandable, but it's.
Can you just write one thing on the list so I don't lose it in my
Yep.
head, but it's incentives for student loan payments.
I think I
Also
have this
about
in here,
getting-
but it's buried
Yeah,
in
like
all
one
sorts of
the
other
things
stuff.
About getting nurses to train is an
Yep.
incentive for loan, you know.
Well,
payment.
and I think you said that
Student
there's already a program in place where there's a forgiveness loan.
No,
No?
we were saying.
Okay.
That's what
I
I'm
would ask.
Yeah.
Okay.
Melissa, the Office of Workforce Strategy is working on those level of workforce issues. But I can get more information for the group. And
Great.
Yeah, because it would be nice to be able to say, well, Katie Beckett is being worked on here and that's one of our options, and the blah blah is working over here, and that's another option that we have from incentives or loan forgiveness or whatever, so at least those are some good, things to have.
And there's power in amplification. Like
Yeah.
if this work group says the Katie Beckett people are absolutely right that you should ditch that cap and get rid of
Right.
the wait list, that, that helps build a political
Sure.
swell for things. So it's like, yeah,
Right.
anywhere where there's overlap or.
Can I ask a question about the Massachusetts and, of course, because I remember the woman came and spoke to us like. A
Another
while
hearing.
ago.
Another hearing. Yeah.
Yeah, right. So when their state-run program, do they do both hospice and palliative care from that so they run both?
Yeah.
So any agency that is one of the agencies that cover the geographic area, they're doing either hospice or palliative care.
I do believe that there are some home health agencies where they do not provide a hospice, but they provide palliative.
Palliative care.
Correct.
And some hospices have taken on, are citing palliative care services at their hospice locations for things that are more clinically intensive. It gets confusing, but you can sort of tell, they have a webpage that lists all of their partners, and you can see it's sort of a mix of, the blah, blah, blah hospice. and then,
Right.
Some of it is like,
Yeah.
at-home therapies of various
Okay.
kinds that never touch the hospice space. So they've tried to bring together a group of organizations that cover a variety of service bases,
Right.
and depending on what the kid needs, like maybe they're just going to one place with one partner, or maybe they're going to a few of them, and maybe some of them are coming to the kid at their house.
They definitely cover children who probably would never require hospice or would require hospice as an adult. And so I think that's also, it seems that there's also some coverage for behavioral services or something that you might normally see covered by other waivers that are fairly distinct from hospice. So it's a very broad definition of palliative care. And I think that's something where I think we've discussed, I'm sure there's been a lot of discussion about this, is also, there are limits to what Medicaid will cover, and the biggest ones would be respite care and any sort of family focused care. But there is a world in which, again, that's the too many options on the table, where you have a payer blaster or program that would really be providing just those wraparound services, the ones that tend to be left out of other coverage. But then there would be kind of more of a Medicaid focused, and just try to, the child focused services would be covered by Medicaid, and the family focused services and respite care would be covered by the state.
A couple of the things that have come up with other states, and I can primarily speak to Florida just because that's my experience is with their PIC program that they had, which was a beautiful state-run program that's now not doing well. But you know, part of the issue that I know a lot of hospices had was that they weren't able to ever really truly convert those families into a hospice. Because they really almost dug themselves into a hole of providing such excellent palliative care that the family said, well, why would we need end of life care? And so they never were able to make that switch, but no clinician is going to put up a boundary and say, I'm not going to see your kid end of life to the degree that they need that support. And so it also opens up, and that's not a today discussion, but that does open up kind of that other concern about, or not concern, but I guess other pathway of how do we define the boundary between the two. There might be eligibility criteria to get into palliative, there might be eligibility criteria to get into hospice, but is there eligibility criteria that actually would make you exit palliative care? Are we now too far down the path that you no longer qualify for palliative care? So now you have to elect hospice, or you have to make another
That's a
decision.
really good point.
So, I mean, I think that that's a viable option. That was not why I was originally gonna say something. Why was I say something?
But that was great. That was great.
Yeah.
Well, thank you.
Yeah.
But I mean, I think that this all goes back to, I wanted to bring, I remember what it was. I wanted to bring it back to your point, Dr. Moss, about what are we asking for?
Well, and I think that's
And
kind
what
of
is
like,
the
I think,
payment?
yeah.
Because we aren't gonna ask for them to pay for palliative care. We're not gonna ask for them to pay for, you know,
spa
like.
before we have the spa.
Yeah, or 8 hospices, you know, we're not gonna ask them to buy 8 hospices that have to now provide palliative care. So are we asking them to pay for the task force time? Are we asking them to pay for data, for somebody to do a lot more data research? Are we asking, like, what are we?
Are we not asked, why aren't we asking for some of those, or why aren't those in the mix?
It
For
just
purpose
never
of-
came
We
up
just
yet.
won't be able to get, right, we just haven't,
Yeah.
we haven't put a price tag on what we're coming
Right.
back.
We've
from.
been
So-
guessing and there's stuff,
But
but
the question I have is what do we think is gonna go through initially, right? Like, a lot of it still has a lot more work and pieces to do.
Yeah.
Like, the spa sounds wonderful, but it's not gonna happen right away. And so what does that look like in terms of what the specific ask is current? If we don't have a specific ask, we will come away with, you are doing an amazing job, keep going.
Right.
Is my fear, is wow, what amazing work you've done with no funding.
I mean,
Keep going.
my mind is one of the first things that is there needs to be an education curriculum. There needs to be
And so-
something that's rolled out, not to the degree that I know we've talked about it,
No.
but truly just to be able to go to a provider or to a hospice or to somebody and start spreading the good.
So,
about,
and
like,
we've done
well,
it
that's
informally,
more-
and that goes
yeah.
back to what my colleague did in Tennessee, but we've done that, right? I've
Yeah.
educated
Oh,
hospices
yeah.
left and right, and done form of pure, you know, was paid by Southeast even before it became a Department of Hospitals to do a full curriculum that was grant
Yeah.
funded because of a family, and so we did that, but these have been one-off, and I've done 1,000 educations
Yeah.
one-off, so something more formalized. My colleague, I wanna come back to that, but my colleague, Taylor Aglio worked in Tennessee where she developed through, and you probably know this, but she developed, let me think what it was through. Well, it's not through St. Jude, it's through the Reach, the regional, it's her project was Reach, but so she did
Louisiana,
Reach, but it's
Tennessee.
ECHO, it's the Extension for Canadian
Yes,
Healthcare Outreach
yes.
Project, and they did the Reach work, and she's now a colleague here. Where they did, the Reach stands for Regional Pediatric Education and Assistance Collaboration for Hospice
Yeah.
Nurses, it's all done via Zoom, and it's really, it's not degree based, it's not certification
Yeah.
based, it's empowerment based.
Yeah.
And works with case studies, and so I think there's an opportunity to utilize something like that here in the state. I guess my question is, when we talk about a center of excellence, I was thinking it's more of a hovercraft over the state to me than it is a physical location.
Yeah.
And
Mhm.
right.
Yeah.
And is our first step more something that the sorry, someone's power tech calling me, which makes me worried, but is there something that when I think about that, and I think about the work of the coalition, is there something that is financially funded that could provide us a resource for anyone in the state to call and understand what's going on from the pediatric palliative care standpoint? Is there a way to support so that someone says, because what we haven't even talked about is bereavement. And the fact that if I say to you have a kid, you have a family that loses a child next week, next summer, they want to know what options they have for their kids. Do you even know what bereavement camps are in the state of Connecticut? Do you even know about experience camps and how they did their first flagship this year here, right? We don't even know those things. So we need, and we have read lists and lists and lists, but a grieving parent does not want to list they need direction and they need, you know, when I think about the work of, like, I all of a sudden, and some of this is coming to me as we speak, but when I think about the work of the journey mapping that is done, that Blythe has done so beautifully, like, what if we had a Connecticut journey map that helped us figure out what our kids needed? And what if we put our initial resources into figuring out what journey mapping for families could look like, education and journey mapping, with a repository that allows people to say, I lost my kid a year ago. I know there's some camps. Can you tell me those resources? And there's one place where we, this Covercraft of Center of Excellence, holds that information and has someone that's paid to be present for those families to get that information out.
That's what came out of one thread out of my research, that parents are looking for maps. They feel isolated with all of this and they don't know where to go. And that's living with serious illness, not bereavement.
It's the same thing, huh?
It is.
Yeah.
You don't know what you don't know.
No.
And you don't know the questions.
So in the budget I put together, I do have carved out a vendor to help us with all of our communications marketing stuff, the collaterals, technology-based solutions like a website, virtual navigation,
So-
and customized education materials so people can go to a place where you could put a journey map, something there. So just the back end information.
So I have big questions about that because I'm budget conscious,
Mhm.
and if the coalition is doing some things and looking for funding, can they provide some of it without developing a whole new website and a whole new, do you know what I mean?
You mean separate from the Palliative Care Coalition website?
Right.
So I
think
looked at a whole bunch of.
shopping together. Like, I mean, I think that we
One
have to,
big.
otherwise we're just duplicating,
Right.
right? And
Yeah.
And here's the thing, we don't have a sustainability. We
No.
brought the best of the state together that care about this.
Yeah.
We all walk away, we just don't have the best sustainability for
Right.
this isn't like there's 400 people that are desperate to make sure pediatric palliative care happens, so we have to keep the people that are engaged and interested moving forward on this. So we can't ask, we just shouldn't be duplicating efforts in any capacity is what I'm trying to say.
I went on the website, the PBCC. is that
Yeah,
what it was?
PPCC.
There's links that go to links that go to links. And I think what we were talking about through this champion care thing was simplifying so that they had access to everything that was in the back end, everything through PPCC, everything through all these other things that people wanted to go there. But there was a more concentrated, like a Connecticut journey map, something on a website that, so they could go there and.
So that's a matter of formatting, and we can
Right.
go to the coalition because we're paying, we've spent $150,000 over these 3 years. If it needs tweaking and formatting, a different lens, a different look, they'll do it.
Mhm.
They're happy to do it, but we'd be repeating
Right,
the
no, I
national.
understand.
Yeah,
Yeah, no, I understand exactly what you're saying. You don't want to duplicate. I
right.
think what we want to do is simplify and, I've said this before, I'm the canary in the coal mine. If I go to a website and I can't figure out, because I'm not an expert,
I'm the same way.
what I need to find out, then I'm just not gonna go there anymore. And I know I went to the PPCC and I'm like, oh my God, there's so much information here, but how do I even use it? So is there a way in terms of collaboration with them of just simplifying something?
Yeah.
You know what I mean? And I think there's two different audiences. There's the
Right.
families and there's the practitioners, right?
What I,
Practitioners need that depth.
right.
Families need something else.
So I liked having some sort of paying a coach, a navigator that can meet these families and say, what you need now is to get on the key Beckett waiver list.
Right.
You need to blah, blah, blah. They feel in just, it's a small qualitative study. I appreciate that. But they feel isolated and not knowing where to turn to. And acute care, you're wonderful. Everyone says. 100%.
Don't believe most of it here.
But when they get home, the community was overwhelming.
Well, or in loss, it's overwhelming because they, I can call them and offer support, but what they need is tangible things to do, and they can't link to find them.
Right.
Champion
Right.
navigator.
There aren't, right? So a champion navigator, a champion
And I think it's.
journey map, a champion repository.
Right.
I think it's very
Yes.
similar to the work that Jessica does. Because you're the linchpin for directing families.
It's the coordinator.
Yes,
The
it's-
whole,
I wrote.
We
down-
call the I call it the care
How
navigator,
do they
because it's sort of a.
Yeah, so
How do they
you
find
even
you?
get there?
So
Right.
when a child dies of Connecticut children, they're automatic, this is a state funded program, they are automatically referred to that program when we enter palliative care, that's part of our. We have a brochure that's part of the packet, so families can initiate it on their own. We can refer them and this is an opt-in program, but if it's really something that the state is providing, then anyone at Yale, anyone who's seeing these patients, pediatricians will have access to this, like. Sounds like you're really thinking about, you want nothing but a most in place, and you don't really want to meet the Dr. Moss who's gonna do the most, well, let's refer you here, have that comfort, begin that conversation. And then you send it back to me and say, now they're ready to meet, can you see them for, they just need a most in place, or they want to travel.
Dr. Moss, who pays for, which agency in state government pays for that? And if you say DPH, I'm gonna be so embarrassed.
I'm sorry, say it again.
Which state government agency is supporting that care manager right now, or that navigator?
No one, we don't have one.
They don't have, she's saying,
Oh,
what
I'm
we
saying,
need is.
I'm saying, isn't
Oh,
this what you think about a
Oh.
center for excellence, this is
Yeah.
what you do.
I thought there was one. CCMC.
No, we don't have
someone.
something.
It's like a state position.
Okay,
Well,
there's
it's
someone at
Center of Excellence of
CCMC.
Pediatric Palliative Care is what
Right.
it is, without.
And maybe that's what we should call it.
Right, and it doesn't have to be, housed, we can use an address, a regional, if we need a working address, but it's really more, a lot of this care navigation work can be done remote.
Right.
Yeah. Oh, absolutely, and I think the main thing is the number.
Okay,
Who
so
answers the phone?
here's
Who
the
answers
thought I
phone?
had with Pennsylvania for this group. What if there was a person that we all know that would be interested in being a care navigator? They would get paid and their role would expand to meet these families where they're at. But they'll know what the PPCC website has and what needs to be built out futuristically. Someone that we know.
Okay.
But connected to the work that we're doing already.
Very.
Do you know?
mysterious.
Oh, I haven't asked the person, but a person in the know who would be able to continue on with the coalition in the newer image,
I don't think we can go ahead
ahead
without having.
Yeah, we have to have it approved anyway and say, okay, so what would that salary look like? Because the state's paying it.
Right, and who does that need to be an RN, or does that need to be a case, is that an RN with case management experience? Because that's really what you need, is someone that's done case management in the hospital system and understands, that's how you build some of that, or you need someone who is a case manager or a partner at that.
Yeah. Well, when
Yeah.
we had our conversation, we kind of talked through like what that looks like.
We have to say 4:30. I think because Peter hasn't said anything.
I know, I don't know if he's there.
Are we good till
Peter, are you
4:30?
okay?
Can you say that again? Sorry, I was away
Are
for
we
a sec.
good? Are we good until 4:30?
You're good. I thought you guys were going till 5, but yeah, you guys are good till 4:30.
Oh, yay!
Okay.
Oh, she's like, would you present to get back upstairs?
No, that's fine, no, stay as long as you want.
Okay, no, so go ahead.
I wanted we had kind of talked a little bit about what that could potentially look like if there was something like that. And I think what's really important, and maybe that's why you put 2 here on some of these, I know you like the under nursing side of things, but one person being that for the whole state is a lot. I know
Oh,
that person.
Oh, absolutely
Right.
not, I'm talking about the hoverboard that has.
Right, I
the
just mean like
hovercraft
from
that
like
has
a
multiple-
care navigation standpoint, I think it would
Yes,
be
yeah,
like
no.
a 2-person
At
operation.
minimum.
But going to your point, like being able to partner and have like a clinical, a psychosocial, or, like having like the full scope of that.
Yes.
To be able to offer that well-rounded support. And then I just wanted to say that I see the gaps in care that happen for providers, for families when they're near the hospital, because they go home into the mysterious unknown.
Yes.
And I imagine that having somewhere that that they're connected to, whether it's indirect or direct, would also be a weight that's off of your shoulders here in the hospital, knowing that there's options. And on our side, like on the hospice side, when we have kids that die in the hospital or that are in the hospital or they move away, it's the same feeling of like, we're into the unknown and we don't know what's happening. And like sometimes we get updates, but like being able to know that there's options on both sides that kind of meet in the middle is so incredible, and it's such a great equitable option for families across the board. So they don't have to decide which way is better. It's which way is whatever
Well,
happens.
so
And
Let's see, but where are they handing them off to? So, yes, this position would be great, and we need two of them, and when the phone rings and they say we need this.
So it's not an expectation that we are gonna provide what they, we're gonna connect it
Give
with
the
the resource.
information.
Right, this is, Experience
Okay.
Camp is hosting a camp a week, and then, so a patient with sickle cell that we follow closely here, his mother just died of the flu. We're sending him home. I'm sending emails to everyone I know saying, make sure they know about Experience Camp, make sure they know about this, right? We're bereaving a child who lost a parent. That's not even in my wheelhouse technically in my bereavement committee, but I sure as heck was making sure those referrals were made, because this kid's gonna have a long road once he leaves this hospital. And so it's the connections, it's the handoff connection. A mother, a bereaved parent is gonna take advice from anyone who seems to know what a bereaved parent is.
Yeah.
Which is why, when I see them in the grocery store, they're scrapping papers of stuff that they, right, it's why everything we give them, they hold on to and take into the next place, but to just say like. You're right, because I do connect with these families, when they come back to our bereavement events and they say, we just miss you. You never can be enough to a family once the child's passed. You just can't, because you are their life, especially the babies, right? I'm their family. If you've never left the hospital with your child.
Yeah.
I'm the closest aunt this baby has, right?
Yeah.
Right.
And so there is so much meaning in that relationship. Any place that supports that relationship and the places to go with what they carry. Right, and I love this, there's that movie Hamnet just got a lot of attention. I don't know, there's a new movie Hamnet.
Oh my, I really need to see it.
Yeah, I need to see it. You saw it?
I saw pieces of it, like in my other life, I do some film stuff, but
Oh.
not as much as this one.
Oh,
No, he does more
wow.
film stuff. And so, I would just need to go see it. I've looked at all the background stuff. It's a very well put together film, and it's just so relevant.
But and it's the precursor to Hamlet, and why Shakespeare wrote Hamlet was because of the death of a child. And so it's a grief, it's a story. And I love the actress who just won the Critics' Choice Awards. That I know this totally digressed, but it's worth it. She won the Critics' Choice Award. What she said is, it's about just holding that space to carry the heavy load, right? It's to acknowledge that the heavy load of grief just needs an extra set of hands. And it's so true. Like it's creating the space for the grief, but it's also just saying, when that box falls, I'm right here. Which doesn't mean I'm fixing it. I'm just standing in it with you. And that's potentially what a center of excellence could start. Yes, we need education. I still want nurse pronouncements for all these babies. There's so many things I want, but what about starting with a place that we know is a touch point for all these beautiful pieces of work to come together? And the reach, we could talk about Taylor's Reach program, and whether we do remote education across the state. We can talk about how we improve, if we can get a spa that's gonna then change things, and then we move towards the changes. But what if everything came together? And the Center of Excellence was less about just teaching, but just the repository of what Connecticut offers currently, and how we can
And then how it
expand what we
grows.
offer, how it grows.
So am I
scalable.
Yeah.
In my former life, we had a very sophisticated education, consultation, handoffs, everything. Yet our clients, who were really brilliant partners and managing directors, would pick up the phone and call me and go, Melissa, what do I need to know? Okay, well, you called this person, so I send that person a message saying, so-and-so is asking me about this. And, it's sort of the case navigator or the care navigator. It's that navigation piece. People want the personal touch. They don't want a virtual, some AI thing
Right.
doing that. They want someone who they can talk to that can help guide them to the next steps. And that person, yes, we need 2, we probably need 5, whatever the right number is long-term. But those people will know the landscape of resources and contacts and websites and information to help get people to exactly, each child has a different kind of condition. Well, that person will know you should go to this place, or you should talk to this person, or this practitioner has this expertise. And so they're kind of the hub and all the different folks around them.
And it's also it's a dual relationship too with the providers, because as you're reaching out to another hospice and you're saying, we have a family that's in your area that's really looking for some support, and they go, yeah, we don't have anybody that speaks here. Oh, can you tell me more about that? Correct.
You could be feeding it back.
I would love to
into-
know more about why you don't think
Right.
you have anybody. Oh, well, we haven't had any training. Oh, that's so interesting because we actually offer training and I would love to connect you with our education department so we can make that happen. for
I
you.
love your feedback on this. I appreciate that conversation. I do have a little concern about doing this network and offering education, but not having people come. So we offered certification education, we paid for it. We reimbursed the exam. It's like pulling teeth to get pediatric nurses from all over the state to sign on for something free that will better them in their work that they're already doing. So when I find in students in undergrad, if I introduce a new module and say, you have to have this completed, and there's the whole carrot and stick. And when our nursing profession came out and said all undergraduate baccalaureate students nationally need to have serious illness education, that was the stick. Now all schools of nursing are scrambling about how are we gonna do this? How, what do we have to demonstrate? What's the incentive? Is it monetary? Is it management? What's the incentive to have your nurses? Branford. Whoever else, VITAS. Come and get this education so that they can receive patients.
So
What's-
they don't want to receive pediatric patients. So if we could talk about our nursing pool, we have very few that'll say. I don't wanna. The other thing I have to say for us, like when the education things were to be certified in hospice in the. What
Was
were
it the
the, which,
palliative care certification?
Yeah.
Gates?
I did have a question. I wasn't sure what you were asking for.
yeah,
Yeah, it could be any of them on the list, the CHPN or the APRN or the RN or the PEDS.
right, cause I remember most of our nurses are already,
Right.
so we're talking about the pediatric ones.
Okay.
And that to me is like, there she is, where I don't know how to get her out.
I don't know how to access
to-
that
Yeah, like I don't,
to get my certificate.
no, I mean, no, I sent
something
them,
that we
no,
had
I sent
recently
them to
talked
the
about.
nursing directors, and I said, here's, you guys need to get to whatever, so if they didn't, then that's, a different story, but then the other thing is. How do we, so what does that look like? I'd be more than happy if she wanted to go, then absolutely.
But that's different than the adult, like the adult, I know how to obtain the adult. It's the pediatric that seems
No, but this was through Fairfield that Carrie
Oh,
had,
There was,
Carrie,
we were providing the scholarship.
right,
It was through HPNA.
Okay.
But leaving this meeting, you would know that there's now a place to call and say, hey, I'm a provider and I learn more about palliative care in this state. I'm moving to Connecticut and I am board certified in pediatric palliative care. What programs are in, where do I look?
Yeah, so as a nurse, you're asking me what incentive why would I wanna go get my certificate?
Yes.
I mean, I wanna do it just to further my education. I don't care about money reimbursement, I don't care about, I would love to find the time to do it, to work that into my workday that I'm getting paid for, but would I love for regional to pay for my to get that? Of course, but I don't. And then I'm not gonna ask for like $1,000 a year to hold that, you know what I mean? Like, that's not my goal. My goal is to become better educated, to better educate my families. So like when I worked in the emergency room, I got my CEN, I got my certificate in the emergency department. That was just so I had more knowledge.
I think what would help, what helps hospices, if I'm just speaking frankly, is that it takes care of peds sexual part. It does become, and there's an aspect of marketing within that. Because it does make you stand out against all the other agencies. There's a lot happening in the hospice landscape with affiliations and partnerships and everything else. It really helps, I think, further the foothold in the community when you can offer something that is so close to the heart. Do I think if the state offered a stipend to the hospice that's offering pediatric care would help? I do think that would help, but it's probably also a drop in the bucket for what's actually needed. Right, because if you're hiring a pediatric nurse. A stipend my understanding is the stipend doesn't usually fall in hundreds of thousands of dollars.
No.
Right, so like, it's not necessarily offsetting the cost that you would need to actually cover the nurse, but it could be that you get a yearly stipend for ongoing education for pediatric. For the pediatric staff, or people willing to serve pediatric staff at your.
Well, we have a scholarship fund that they have to put in for.
Right.
To, do whatever, but what you were specifically talking about was the scholarship thing that you were running at one point, correct?
But if,
But it was a
Talking
one-time.
about like
It was a
champion,
one-time
right?
thing.
but no,
No.
if our goal is to take Taylor's model, if that, I wanna look at it, I wanna see, I wanna learn from it. If that's the model to reach so many different hospices, to get Branford off the ground, to support regional or whoever else. How do we get
the buy-in.
this buy-in?
So Eileen, if I can just comment real
Versus
quick on that,
individuals.
it's leadership. Leadership is how you get the buy-in.
Yeah.
So we have centers of excellence programs across the country in other entities of care. And when leadership supports quality, and quality is through enhanced training, then we do tend to see more certified professionals. To Jessica's point, there are center of excellence programs and other licensed provider types that offer reimbursement incentives. If 75% of your staff, for example, have the expertise in XYZ, we might give you $1 more a day. And in that whole world of reimbursement, $1 can make a difference depending on, the scope of the people that you're serving. So money is a great stick, whether it's, to Tony's point, paying the actual professional, or if you're enhancing reimbursement through a center of excellence programs. There's lots of research out there about that. We have a legislative mandate at DPH to develop a center of excellence program for nursing homes. And there are domains and measures that are developed. And if there are appropriations for that, nursing homes could perhaps appreciate a higher reimbursement per day based on lots meeting these measures, which speaks to credentialing and expertise that your staff may have. So that's always incentivizes why those 8 nurses should go back to take the exam or whatever it is, the requisite that they need to finish this.
And we do that, we do that now.
So I guess the question is, would there be a budget line for this? That Branford Hospice will get $5,000 if 50% of their nurses are certified?
Well, so you're talking about an organizational basis versus an individual nurse
Well,
basis?
I think you could go either way. Yeah, right. I think
Yeah.
you could go either way or maybe both, but I mean, if you're a pediatric nurse and you're providing care to patients, you know that what you're doing is unique and you know that what you're doing is not, I'm speaking for you, is special. And not just because of the nature of the work, but because you know other people won't do it. And so you know that you are a hot commodity in a sense of that, but like, it's a lot of work. And you don't do it for
Easy, Jessica.
No, but you don't do it for that. But if there was something to incentivize nurses that aren't against working with kids, right? They're not necessarily gung ho about it, but like they're willing to take the training. And then maybe they are willing to take that pediatric patient. And then at the end of the year, they see a $500 bonus at the end of their, like on their check. That might make a difference. If you're actively serving.
See, first of all, I think you should resend that, because I thought it was just a one-time deal that you were providing this training. That's what I sent to Carrie Shield. Yeah, so I thought it was just that one-time thing.
Wait, it depends on how many follow through and take the exam this go around, if I'll offer it again. So for adult nurses, we had a terrible response to those who sat for the workshop. They didn't go forward and take the exam. And leadership, adult Hartford Health said, well, we can't make them. And our scholarship, I think we spent $10,000 or $15,000 in supporting nurses. and maybe 3 or 4 went through. Okay. Right. So it's.
I'll tell you where I
And that
struggle,
was leadership
right,
all over it. Yes, our nurses, we want this. We want to be able to say in our, in our reports that
right.
such and such a percent
And
have
I would-
certification.
I would argue with a large health system, but like for me, regional hospice, little nonprofit, I have, how many case managers do we have? 9?
Yeah. Since 8 to 10.
If I start pushing for them to do something they don't want to do, they're gonna go to Hartford and work and not get pushed to do it. And then I have 8 case managers. It's a and it's hard to push. Now, we do a thing where we incentivize by, if you go for this
You do it, right.
certification, we will reimburse you and you get $1,000 bonus.
Yeah.
It's the carrot versus the stick, and the
Yeah.
carrot seems to work.
Well, right,
Right.
and most of them have done that, so now, like, Beth would be the one to do, the ped one, the other ones are like, okay, I'm willing to train in peds, like Beth can train me so I can go out. The evening people, let me know a little bit, they don't wanna go for.
Yeah.
An
So-
So
extended,
could the
we
state
have-
reimburse it a similar way that you have been able to?
correct, but I can't, I mean, if I start mandating things, no, but I mean,
Not mandating,
when we
it's-
talk about like leadership. You start mandating things, they're gonna go to Danbury Hospital and work and make probably $10 more an hour off the bat and not get mandated to do anything. So that's where.
Just, I'm
Like
thinking about
heartbreaking.
proposal,
Men's
I
and-
don't wanna have a metric saying that we're gonna have a 25% increase in national board certified
Right,
nurses in the state.
right,
And we can't.
Yeah.
We can't sense it.
We're just having a stipend kind of built in
Yeah, the
to help
stipend budget
incentivize.
is-
Even with certification is it's beautiful, but it's the comfort to do the work. Is
Mm.
key, right?
Right,
It's the willingness and comfort to do the work.
then we don't need to have it in as a metric,
So,
or do we?
right.
I'm just saying there's barriers to getting it done.
so are you saying we probably shouldn't list certain things in here?
Well, I think
As
as we
sure.
Goes back
talk
to our
more here,
conversation of peeling back.
this has to
Right.
really be
Don't
peeled
promise
back.
what we
Right.
can't do. Cause then it's a fool's errand.
So my goal in setting forth these numbers was just to say, I think we need to estimate X amount of money in order to address these things. If we don't need some of these things, we should just line item them out.
I would almost say like maybe transferring instead of like the FTEs for nursing, like transferring some of that to go towards like an education stipend for nurses. And we don't necessarily have to outline the terms,
Okay.
but I think just kind of building that in to say, this is, your money would be directly going to us being
So
able
it's a
to
list of things we
increase
want to
education.
pursue, okay.
Yeah.
But
But
then-
then you don't need to explain too much of it. 'cause I think-
Exactly.
Yeah, in like the
Yeah.
Katie Beckett working group's recommendations, which was similar in terms of, as an interim, and it was a discussion of if we will continue to do this work. It was 3 pages. And there was a number of bullet points that just said, we want this. And so I think that the legislature does seem like they'd be amenable to that. Although, of course, as we discussed, that, finding the policy window and making sure that there's enough detail in the way, yeah. But in terms of like, the particular line items in the report, I'm wondering whether just focusing on the idea of champ care, focusing on building out the program, it makes me think a little bit of something, things that. I know that, Connecticut, the perinatal quality care collaborative is rather small, but I know some other states like. California, they have the maternal quality care collaborative and their perinatal one, where it seems like it's a circle of centers of excellence. It's like, so you have, it's a collaborative, but you do have the arm that's doing research, you have the arm that's doing education.
Right.
You might have like an onsite, I know at least in California, their maternal one, which I'm more familiar with, they have like an onsite component at Stanford. And so they do some work there, but that's not the entirety of their work.
Yeah.
And so I'm wondering whether just for the purposes of this report, all of the really, like, this detail which needs to be worked out, I'm wondering whether the legislature just like, we get these together, just like good money. And they're probably not gonna be worried at this point about a couple $1,000s or $10,000 of work. They're probably gonna be thinking about like tens of millions of
Right,
dollars.
right.
And so, wondered whether it would make sense just to kind of put a number out there and just say, Champion, we're talking about, it's the hovercraft, we're talking about the goal of this program is going to be to help families and providers navigate the care that's currently available and put work in and develop a future directive for care. And so the CHAMP care will continue to grow and will always encompass whatever care is currently available in the state of Connecticut, but that care is going to change and grow over time, directed in part by CHAMP care itself and its relationships with providers and its relationships with other existing.
See, and I agree with that, because I think we've done something, like we're talking about CHAMP care, okay, so, and then saying exactly what you just said. So the money really, what money do we need is, okay, if we want to be able to start that like ASAP, who's answering the phone? How many people are answering the phone? You know, but then everybody's gonna need education too, like who's educating these people? Arnold, like you just said to me about the camp in the summer, I don't know, so who is educating these people and where they're supposed to go in the direction? Maybe for the first year, it's a lot of, can I call you back? You know, I don't know, but I think that is a good, and if you're saying like limited as to, 3 pages, then maybe that's.
I think it probably could be longer than that, but.
I think worth considering like a little bit of a hybrid format, picking off, it sounds sort of.
And we want to maintain as much of this amazing work as possible.
We'll keep
Yes.
it, but I haven't, I just went down and went through and kept 6 pages of stuff that needs to be revised and reframed, but something very simple.
I think the balancing act with where the group seems to be headed now, and correct me if I'm sort of summarizing incorrectly, but like you want to make sure it sounds like you're ready to make a concrete ask in the immediate term vis-a-vis navigation and some of the initial educational pieces. But you don't want to let the legislature think like, if we do that, if we spend this 50K on this navigation program or whatever, we've done it. We've solved
Oh,
it.
yeah, no.
But they could, like,
yeah.
it sounds stupid to you.
Yeah.
and
No.
trust me.
The challenge is, year one,
Why is every other state?
this is a plan
Yeah.
to get to the big
Right,
plan.
like
And
just,
so the question is, do they ask what's the big plan? Well, we don't know what the big plan is, because that's what. we're
but
gonna
it's
be
worth
developing.
doing some
I kind of
flag
do.
planting, I
Yeah.
think, of saying like, again, like, we know that the big plan has to include some version of these core elements, but that
Right.
can't happen overnight, and so, like, what you need to do now is both help create a navigation resource immediately and some essential educational resources immediately, and then put us on a path to doing some of the other things, or something like that. Just don't let them get away with thinking
Yeah.
that like that's
The objective, the understanding that
Yeah.
like CHAMP care is the objective, it's like the
And
ask
the
is
two
yeah.
big pillars at this time is workforce development and resource.
And you could break out, again, I think it's worth
Alignment.
mentioning some of the bigger elements that could live inside of those buckets to the extent that they've been identified, so that they have a sense of
The
what they're.
SPA.
All that stuff, yeah, like, because someone like
Yeah.
Anwar will see
Yeah.
that and be like, okay, like,
The
this is the like,
scholarships, the
this is the
stipends.
type of exercise we're thinking about.
Yeah, I think for, the sad lawyers who are in the legislature who are just have no experience with healthcare and would look in, as we've just been like, I don't know what an FTE is, I'm not really clear what's going on here, is that, but they would be able to say like scholarships, like stipends, right, and then that hopefully would give flexibility just to have the resources necessary to support this work in the future, but without having to worry about someone, taking their experience in tech or taking their experience in farming, or I don't know, something, and trying to match that experience to healthcare. So it's something, I mean, I'm sure we've all seen it, but it's nice. I've been in some situations where like I don't realize how much technical language I'm using because my understanding of my technical language has just been so immersed. Like sometimes when I do like appellate work and I'm like, oh wait, these are not normal terms. This is not English. And then having conversation with someone, it's like second and third conversation. I'm like, oh wait, we were just nodding at each other. Great. And then just recognizing, yes, just for the legislators rather, is that, what can they read quickly that will resonate with their experience in the legislature? That gives them enough of an understanding of what healthcare is like, what this particular space in healthcare is like, without freaking them out.
So
And
here's
not
a,
letting them off the hook.
And not letting them
Because I really do,
I
I
was
mean,
thinking freak out
part of
instead of
my-
like letting them off the hook, like, oh, we're not dealing with this, we're done,
Yeah.
we solved it.
right.
Yes.
So, I mean, there's phases, right? Phase one is our framework development. We're
Yeah.
focusing on education and training, navigation for services, those types in details. Being phase two is a more fully fledged champion care structure. I'm taking out the pilot concept because that kind of implies we'll be
Program.
We want to
Yeah.
program,
right. But we may or may not be at the program stage, but at least having something in place. So that this will become neutralized. The question is, do we talk about potentially pursuing legislation? Or do we just get rid of that, knowing that we'll probably be talking about?
As
getting
in
back-
asking for legislation. like,
Yeah, 'cause I'm-
this session.
Well, I'm thinking about whatever the legislative cycle is, because you guys mentioned that. Do we need to put something in the queue for them, knowing that maybe by this time next year?
But that's maybe the navigation type ask. Money for something of that scale, they could conceivably appropriate this time
Yeah.
around.
Okay,
When I read the version of the report, I was like, if the plan is to ask them for like millions of dollars, to try to stand up a more fleshed out, like Massachusetts stuff, that for this February might be like a little bit tough, because like the clock is gonna start here in February for them, and it's a short session. And like realistically, that like bills that are gonna come up have already been fleshed out, but something like the Navigator House could be tacked on to another existing bill or put in an appropriations line. And so yeah, I think that if this group feels comfortable enough with what that sort of phase one looks like, why not ask for it now and get the money and get started? But I like the idea of a phase, like presenting it as a phased approach of
Right.
like, there's more coming. But
Yeah.
right now we're
Right.
asking you for part one, and part two is likely to include, these two buckets filled with these things.
Yeah.
but what are,
Yeah.
sorry,
Oh, no, so making sure they understand that in order to move forward, in order to go forward the phased approach, or even the modular, like a modular approach, you have to do both workforce expansion and some sort of payment reform, it's just in that world. And I think that might be a way to make sure, not let them off the hook, but just make sure they understand is that if there's gonna be a landscape for someone to navigate, the legislature has to do these things.
Well, and we have talked about a little bit, just the notion of, because this is a relatively cloistered role, where like lots of folks don't have the knowledge that in between those two phases, for instance, you could do like, host a bring legislators into some spaces that educate them like in between sessions, so that by the time they get to the next phase, the next go around, like that some of your key
Yeah.
allies have a better sense of what it is you're asking them about.
so if I left the line, right now I put a line in legislative analysis, research and proposal development. And I just threw a number on the table, but I don't, is that an adequate
Wait, can you say,
description?
what did you just say?
I put a line item in here, legislative analysis, research and proposal development. To deal with the unknowns around legislation. I don't know if that's the right description first and foremost, but
Are you asking for a consultant to do that, Melissa, or?
I don't know if it's something that Yale does and they get paid for it, or so. I think if we're going to mention it, is there a cost for something like that, right? Or is that,
I don't think it's necessary.
know?
I think that there is a possibility here for, listing out some options. And then just making it clear to the folks who are gonna be reading this is, why this kind of collection of options on the table, very broad, but just the idea of a state plan amendment or a waiver. And we're not saying that like, yes, do one of these things, but making sure that the legislators know this is kind of the ballpark.
Like a
we're
heads
looking at.
up.
Just a heads up. And I think for some of these, we don't necessarily need to include any sort of budget line item, because the state would have to probably eat some of those costs, because DSS would be using their own people, they'd be using their accountants, might be doing their own consulting work. So I think for some of it,
Okay.
it's things that like they have to do it, because in some cases they're gonna be interfacing with the federal
Yeah.
government.
Okay, well, that answers my question.
Yeah.
Thank you. And I did have, there's a slide in there, it talks about like the ask, there's something pursuing developmental legislation to guide changes. But
And
I think
Elle,
that a little bit-
you had mentioned something about aligning, and I started to write it down and then I didn't get the whole concept. Aligning palliative care with concurrent care, which you had suggested. I thought I heard that might requires some legislative change. And I wasn't sure if
Yes.
that was at the state level or the federal
That's like
level.
next phase, right?
Yeah.
That's like the heads up phase.
Yes, and I think this is the unfortunately like really annoyingly complex and confusing part of it where like full integration of palliative care and hospice care for peds or for adults is probably not possible unless there's a massive change at the federal level. And that's because it
Okay.
would require at minimum changing federal regulation. However, there are other opportunities to get as close as we kind of possibly can to integrating palliative care and hospice care through building that bridge. For peds specifically, and then, you know, adults that, you know, those advocates can hopefully take from that. So that would not necessarily require any changes to federal law. And then that would be some sort of the options we've been talking about for building up a palliative care benefit. And the purpose of that would be kind of giving language and giving structure to that, you know, non-clinicians, non-providers be able to understand. And then in that way, helping to actually build up hospice because you're making it easier for non-providers to see what's going on. But of course, in a way that's doesn't scare them and make sure we're not getting too far over our skis to make sure that, you know, we're not telling the wrong people the wrong thing and then they decide we don't need this anymore.
Well, as we navigate through our reg revision process at DPH, because we are currently at home health and hospice, is this a pivotal moment for us at DPH to maybe incorporate language or that would clarify or make that clearer? And we can always ask at the state level for, we do vary from our federal regs and our state regs. In some cases, our state regs are more stringent than the federal
Right.
regs.
And then we have to follow.
Yeah.
But is there
Is
there
state
an
trumps
opportunity
federal
here
in those cases?
to do that?
I mean, this might be a place, and this is probably a conversation not for this report, but for later. But again, just from the legal perspective, this might be an additional incentive, is that if there was, in theory, if you had regulations about home health and hospice quality, is that you could put something in there about staffing. It probably would be challenged, I would imagine, but you could say that, you know, if you are working with this population, you need to be availing yourselves of these opportunities to, or you have to have this particular type of training. Double-edged
Okay.
sword, of course.
Okay.
You know,
We've done
but
something
yeah.
like that already.
Okay.
In our regs we haven't called out we're calling it special populations. Because home health is changing and it's predicted the evolution to change significantly as more people go into community settings. So I think we're on the right track then. Thank you.
I would just add one more thing on that, is that there potentially could be an opportunity at the state level to clarify how concurrent care works. That would
And
I don't know
probably,
that they know. Like, I
And
don't
would
know
that
about
be
everyone.
at a DSS payment side or on the DPH health regulations?
I think that would probably be both.
Okay.
Yeah, probably more on a
All right,
language
let me
side.
let me think about that then.
That might be a large undertaking, but, and this is something where I don't know, it's something that we, the Psalm Center, could potentially research a little bit more. Is there might be a way to enshrine concurrent care in Connecticut law that doesn't actually require any more money, it doesn't require any sort of waiver, because it's already there.
Yeah.
So that also could be another option.
Okay.
That's important as we
Yeah.
also navigate ACA in the future, just knowing that there is some protective mechanisms that are in place at the state level to ensure that that's accessible in the future.
Yeah, and I think those regulations, they would only work insofar as concurrent care is enshrined in federal law, but at least it would provide a little bit more comfort and security. But then I think I think some other states have gone forward and they have had a state plan amendment, and they say specifically that concurrent care is a feature of their Medicaid plan.
Yeah.
A Medicaid program rather. But that's also, I don't think any of this is like for this particular report, but this probably
Yeah,
would be
right.
information moving forward, but just on the reg side. Is that
And when you say that, if it's concurrent care is built into something, into a Medicaid program, are you saying then if the Affordable Care Act, if something was to happen over the next 3 years, it would still be part of your Medicaid program?
In a particular state, yes, assuming that the federal government does not try to do something funky
Okay.
with Medicaid, which is. But in theory, yes, is that once, because it would just, the state has a number of options, a state has a number of options for saying that, yeah, we do want to cover concurrent care. You could either modify the hospice benefit, you could also say this is a type of medically necessary care, because the EPSDT benefit gives a lot of flexibility. That's basically just saying if you have a kid and the kid is on Medicaid, almost anything counts as medically necessary, and the state has a lot of options to add additional services and to codify those as medically necessary in their own regulations. And so I think it's another potential option in future. And this is something where, not for this particular report, but something that could happen through Champ Care is also more collaboration and almost like a movement organization with other advocacy groups, because especially through Katie Beckett, or I just know my personal life with, you know, friends and family who have children who are chronically ill, who have serious special health needs, who don't require hospice, but you know, it's kind of long term. Is that some of those groups require more resources that if they got them, it would not take resources away from this population of children, but having multiple groups working together could also help convince the legislature to do bigger things. I mean, I always just have the dream of just like really using that benefit and just being like trying to get as close to like whole childcare as possible, and really trying to break down as many barriers. But that's something where, you know, it could potentially be achievable. It probably would require a lot of people working consistently together. Just like hundreds of people.
I'm gonna drop off. I have to go be somewhere at 5 o'clock. I'm gonna update Regina and let her know all the conversations we had about the spa, because it impacts DSS significantly. So I'll just prime Regina that we had the conversation, so that she may want to share with leadership at DSS that this may appear in the report. So there are no surprises. Thank you all. Sorry that I have to drop off.
Thanks,
Bye.
Barb.
Nice to see you all.
Oh, that's why she got, okay.
That's why she's.
So, where do we stand? Well, it's clear simplification. So a lot of this will just be stripped away. Things will disappear.
I think it's good that it was,
Keep it.
was done.
Oh, yeah. No, I
Keep it.
you have no idea how many versions of copies I
It's
have.
actually going away.
This is gonna grow and go forward.
Yes, yes.
Yeah.
I think assuming we get approval from the legislature to continue and we get enough funding to make this real, we're gonna have very dedicated work groups going forward to zero in a lot of the stuff, because if we're talking about a 12 to 18 month window for this framework development, there's a lot of different streams of activity that are gonna have to happen, right? So we'll have to talk about that after the fact. But then, you know, the question is, you know, getting everybody's input. I'll try over the next week to simplify this and pull in all these ideas. Peter, you're gonna send me a transcript from this meeting?
Yeah, I'll send you a transcript.
Thank you. So the transcripts go 5 minutes and 30 seconds, you know, yada, 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 yada. And then it'll say Tony and Marcion, yada, yada, yada. And next line, 10 minutes and 30 seconds. So reading, it's like 75 pages of
Oh, God.
one after the other. So anyway, it's
Why don't you just watch the video?
yeah, right. It's harder to
was gonna
listen
say,
to it again.
oh, yeah,
There's no
that's
video,
true.
listening to it again, but I usually
yeah,
can
yeah.
kind of tell who's talking. But I'll come back and I'll send it out to everybody. I really want people to look at it and do any type of edits, word refinements, because I think, you know, less is more, obviously. I agree with you. It's like, this is way too long, but I thought in the absence of having too little, too much is
It's much
better
easier
to
to
start with.
No, but
something
that,
and
listen,
distill it
that's
down to its
we've
essence.
gone
Yeah.
over
Right.
these months. We've
Right.
gone here, there, everywhere. So
And I would say
it's,
we started this in September. Where are we now? Like September, October, November, in part of December, maybe. In 3.5 months, we've come a huge distance
yeah.
in terms of where we started and where we are now. So I think we have kind of a group think around this. So I think we made phenomenal progress, and obviously we'll continue, but I think there's a lot of work that went into this, and everybody's, you know, great ideas and expertise and everything has been incredibly, it's been illuminating for me, but it's just been terrific just to hear all the different things and people coming to consensus.
Well, and for you
on
putting
this.
that together, that, I
Yeah,
mean,
it's
there's a ton of work there.
Thank you, but yes.
And I have to say, next meeting, Eugene, keep it down.
Very chatty over here. I know, I know. My
Anything
colleagues
you
were-
want to add to this that hasn't been said?
I think I just make a couple of very quick points. The first is that in terms of how we should consider our approach, just overarching idea here, something that my colleagues and I have heard quite a bit, we shouldn't negotiate against ourselves. So I've heard a few times over the course of this conversation, how much can we ask for? What is it likely that the legislature would be willing to support? We can't know the answer for that. I think what they want from us is a vision of what the final destination should look like, or what the stages are to getting to where we want to get. And then we'll hear from them what is or isn't possible on the budgetary side, et cetera. Obviously, I think there are limits to what we can ask for, as Elle and Jeremy have spoken to in particular. But that's a really core point here in terms of not trying to whittle things down unnecessarily. Um, I think that we're very much in agreement on the need to keep things simple and to be very clear in the terminology we use. Melissa, you're doing a totally incredible job in drafting all of this, dealing with a field that's very complex. But again, from the legalistic perspective, in the final report, I think it'll be useful for us to be very precise with the terms we're using. And with that in mind, that then bridges to a couple of very quick thoughts on the actual substantive policy recommendation front. One of the things that we have been discussing, and I just wanted to echo it here at the close, is the wisdom on the one hand of a tiered approach, where we make clear to the legislature that there are phases organized around core pillars. We've identified the two that we're looking at currently. But another piece of this is, and this came up in the course of I think what Elle and Jeremy were saying, it's the list of menu options and being pretty precise about that. And from what I've heard and from some of the work we've done, it seems like there's a combination here of things like the spa, state-run payer of last resort, a potential private insurance mandate, and lifting of the Katie Beckett waiver, or working with that in some way. And it may be worth being very precise about that so that the lawmakers can understand if we're not asking for a spa in phase one, that's where we want to go. And if we are thinking about a spa, that's a long-term process. I mean, it takes years. So the more time it takes to pull the trigger on going down that road, the longer it will be before we see a program that is effectuated through that mechanism, if that makes sense. That's a bit verbose, but that's part of the virtue, I think, of being creative in the way that we think about how we do things. If we have a mixed model, say, and Jeremy's in our internal conversations was the one who came up with this particular idea. But if we had the Massachusetts model style state-run payer of last resort as a stopgap before the SPA kicks in, we could also signal to the legislature, you should consider the fact that there may be a funding request along these lines. And this then bridges to workforce, though, because I think in all these conversations we've been having, we've confronted a kind of chicken and egg problem, which is we don't have the workforce. So even if we are able to have payment reform, I mean, we've heard, for instance, from some parents who say, I got off the Katie Beckett waiver and I don't have access to a nurse who'd be able to come. Or I did have access, but the nurse then wasn't able to continue providing care and there was no one who could fill in, right? So how can we build out a workforce if reimbursement isn't there, if the payment structure isn't there? They have to go hand in hand. There has to be a kind of complementarity. And this is part of socializing the legislature, letting lawmakers know, A, what are the terms? B, what are their relationships to one another? That can't be done in this report, but that the report can open a door to. That's also part of, I think, how to think about what we are facing right now. When we present this report, I think we'll have opportunities to talk to the lawmakers about what it is that we have set out. And I would just encourage us to think of this as a kind of tiered approach in terms of bringing people up to speed. Jeremy also brought up this idea of maybe a conference or some kind of convening after the legislative session ends to further deepen people's understanding of what's at play here. But part of the virtue of this two-pillar approach is that they are integral. Each supports the other. If you take one away, the other will not succeed. And if we plant those seeds early on, that'll be extremely successful. And with that in mind, just two final little thoughts. The first is the hovercraft idea, I think, is super phenomenal and very worth keeping in mind, where I think some lawmakers might have a concern with any program that we start to conceive of, is it really speaking to the needs of the state writ large? And obviously, there are a lot of fine points to be worked out here, but just emphasizing that the end goal, the ultimate vision here, is one that can speak to the state broadly, is a simple point, it's a clear point, and it's an important one that could help build a coalition of lawmakers around our proposals. And the last thought here is data collection. I think that we're talking about expanding or preserving the task force or the working group here so that through the phased approach ahead, it can continue to guide what happens and how it happens. But one place that I think the sooner we can get resources, the better, is specifically on data collection. And finding ways through maybe existing state agencies or an augmentation of state agencies to gather info about the patient population that we're looking at and the kinds of care that they need. So that's sorry to kind of condense everything that's been bouncing around my mind.
Can I just ask a question too, for those of you who have done these presentations? Peter mentioned that it wasn't necessary for you to present this to the Public Health Committee, but I think you did it last year and it was probably pretty effective.
Well, we had to testify even to get it forward. That
Yeah,
wasn't
okay.
a presentation of
Okay.
it.
No, yeah.
So the
Just
question,
testified to help support,
right?
you know. But we're not.
So the question is,
I don't
if
think we're presenting.
you're not, but do you
No,
want
I
to?
think-
So, because I think Eugene was just saying, in terms of socializing this with the legislature, and it would be the Public Health Committee you'd be speaking to.
Yeah,
Do you want to do that? Because Peter has to put the request through to Senator Anwar. And if you do want to do that, and we're talking about some of these legislations, should somebody from the Yale team come in to answer any questions about legislation? So number one, do you want to speak to the Public Health
well, it
Committee?
never hurts. I mean, it never hurts to actually, like, so it's almost like when you're testifying, is that what it is? Like, we would go and present and present it at something like that?
So Peter, what's the forum that they could be in front of the Public Health Committee to talk about this?
So, okay, let me just ask someone and then I'll get back to you. Just
It's
to
often the
make sure I get you
case-
guys the correct answer.
Yeah, it's often the case that you can take a written report on its own. But I take your point.
Right
Melissa,
now, they're
that-
saying just a written report's gonna be fine.
Yeah, I take your point that
Question
like
is-
there could be power, like added power and spotlight.
Personal presence is nice.
Concept that was presented.
Well, and that's
Yeah.
what, like, that's what we've done, like, sometimes it's just being there right outside the door and they're coming out for
Right.
their coffee and we're having conversations, or your lobbyist is taking you all around, or so on and so forth, but I'm just not aware of what platform it would be that this would be presented. I
So-
know about testifying to certain bills, but I don't know, so.
So Peter said it would be to the Public Health Committee.
Okay.
You could, but he needs to ask Senator Anwar. He would have to kind of funnel it through him. And if you want to speak about this, if we have something in here about legislation, should someone from the Yale team be there to answer any questions they might have? It might be
Well,
10 minutes of your
speaking-
time,
I
too.
mean, and here's my one thing that, and Peter, I would ask this of you and I, you know. Because I have tried to email Senator Anwar. I would like to actually give even a heads up. I don't want to. Sit in front of the entire Public Health Committee and talk about legislative things that he does not already know about.
Right.
So. I'm trying to do that in the background, but then we'll see what Peter comes up with of what that platform would look like, but I think. Behind the scenes, you know, there needs to be a heads up of what is even gonna be heard,
Mhm.
you know.
So, but you think it's a good idea to speak in person or virtually to the Public Health Committee? I'm just trying to
Sure.
clarify that. Okay. And
Okay. Oh,
having someone from the Yale team.
is my, oh, sorry.
I'm sorry, go ahead, Peter.
No, I thought my mic was dead. Sorry. I don't want to interrupt. You can continue speaking. I'll go after.
What happened?
We were just confirming whether or not Tony and Dr. Moss would want to present to the Public Health Committee.
Mhm.
Okay,
So,
So, yeah.
I think the answer to that is yes.
okay.
Yeah, I mean, and Peter, is it the kind of thing where when a bill is being presented and you go and testify, is it the same kind of?
No, this would be
same kind of thing?
be like a special, this would be like a different kind of event. It'd be,
Okay.
I would assume it'd be you and Dr. Moss presenting to the Public Health Committee
Okay,
regarding your report, like an overview.
okay,
And then how that would happen is, so you guys would send me or the chairs, because I can forward that request to them. You would say that the report, you guys are handing it in on February 6th. I don't want to put words in you guys' mouth, but is that correct?
That's the
Yes.
plan.
So you guys would say that's your plan and that you'd like to provide a synopsis and overview of that, and then we'd handle the logistics afterwards. So,
Okay,
okay.
oh, and also it would have to be addressed to the chairs. It can't be addressed to me, just to let you know, just procedurally speaking.
could you say that again, Peter?
So that letter to request that to present a presentation, it'd have to be addressed to the chairs and not to me, because procedurally speaking, you'd be speaking to them. Just
Okay, so we need, Tony Ann needs to craft a letter from her and Dr. Moss that goes directly to Senator Anwar.
And Representative McCarthy Vahey, I would guess,
Okay.
right?
yes, and then you'd CC me and Beverly Henry, and then they'd look at that request and we'd handle it logistically if they
Okay,
still
and
were.
you'll coordinate the back end in
Yeah.
terms of just the meeting? Okay.
Yeah.
What? I'm sorry, I'm so down.
We just need a letter from you with a copy of the report that goes to the chairs of the Public Health Committee with a copy to Peter and Beverly Henry, and
Okay.
Peter will coordinate that discussion.
Because that discussion is not gonna happen on February 6th, so to say, right? We're just gonna put it
No.
in and then there might be some.
We'd have to
mutual-
We'd have to find a time and date because the short
Okay,
session is
right.
going to be crazy. So yeah.
Right, right.
Okay,
So we'll have to figure that part out, but
and Tony, and I would just say if we're going to be talking about any type of legislative items, maybe including, Elle or Jeremy or Eugene, just to answer any questions they might have about that. You may say nothing. There may be no questions, but at least that way you're not on point for having to answer legislative questions.
Right. We'll just say, I don't know.
Protect you from yourselves.
Tell Jeremy.
Oh, phone a friend.
Yeah. I mean, if you're willing, if that's reasonable, okay.
Yeah, we also, we do have our like slides, which could be like a quick reference that we can circulate now.
That would be good, yeah.
That also can just, because I think we're happy to do that, but also, just like show.
So just so you know,
Yes.
anything that we send to Peter Distributed Group becomes part of public record.
Yeah,
It's so you could do it privately amongst this group, and Peter's fine with that, because this report that went out to you was separate, so.
Yeah, I would say the slides for now are just.
Yeah, just internal,
Yeah.
so.
They're not deliverable, they're just.
Thank you, Jean. Thank you, Peter.
Yes.
Thanks,
thank you.
guys.
I'm to adjourn at
Thank you
5.
all.
Yeah.
Sorry,
Wow,
this is in
right on
person.
I second.
Look at that second.
If we're really doing it, that's right.
Robert's
Right?
Rules of
Okay.
Order, is that what it is?
Oh,
Yeah.
yes. Thank you, Peter. Thank you.
Thank you.
everyone.
have a good one, guys.
Thank you, everyone.
Thanks.
Thank you for hosting us.
Yes, thank you.
Thanks.